I'm John Benfield, one of the main presenters here. We presented last year here with two of our partners. Our third partner wanted to join us, but he, until 2 weeks ago, didn't realize this meeting overlapped with his wife's 60th birthday. So we said, please go enjoy that. Don't be here. But Dr. Ockey says to say hello. This is in conjunction with the Utah Core REMS. So hopefully, if you're here and haven't signed in, please sign in so you can get your required 3.5 hours for opiate education that Utah requires. The overall topic of today's meeting is really just discussing the risk and benefits of opioid therapy and all the caveats and clinical decision making that comes along with that. I don't think the minutia in that has lost anyone here. None of the presenters have any disclosures. None of us lecture for big pharma opioid companies. This is yours truly. I'm John Benfield. I work at Intermountain Healthcare down in Utah Valley. I also am the senior medical director for all of their acute and chronic pain clinics, and then all of our acute stuff we do inside the hospital. I have a specific interest in opioid therapy, especially helping people on high-dose opioids come down on those. That's part of my practice with Dr. Ockey, and then Dr. Romankowski and Dr. Minori all also have that as part of their practice. We also do all the interventional components that's very common with pain, as well as do functional restoration and some of the other pain psychology that comes along with that. Dr. Romankowski, he's one of our other presenters. Dr. Romankowski runs clinics in Utah Valley and also opening up a new clinic in Salt Lake Clinic, which is an interdisciplinary model for both opioid therapy, interventional therapy. He's got a long laundry list of accomplishments that you guys can read there, but he'll be part of our presenters here. And then Dr. Minori is also an interventional pain physician with similar interests as me and Dr. Romankowski. He runs his clinical practice in Park City and Heber. And we'd like to acknowledge our core collaborative, people who financially support Core REMS. And then the faculty advisory panel, along with some individuals in DOPL who aren't on this, who reviewed our slides. I will say right up front, when these slides were submitted, we had data up until 2017. Since then, some 2020 data has come up. I'll verbally review that, but they're not in the slides. If you have questions, I'm happy to share that newer Utah data. Some of the opioid data, quite frankly, we were so focused on COVID, some of the other data, we just have bandwidth to get that in real time, but it's starting to come out now, which is nice to see. So what we're really going to focus on are the bullet points there. We want to review the pathophysiology of pain, how our body recognizes, processes, and responds to pain. How do we, it says accurately assess. I would say, how do we appropriately evaluate? Some patients with chronic pain, it's not a matter of accuracy or precision. It's a matter of seeing all of the things that come along with the pain and following the multiple things that may be causing it. How do you safely and effectively treat people with pain on opioids, not on opioids, and psychologically make sure they're safe? What evidence is there for non-opioid based treatments, whether that's therapies, interventions, medications? We'll discuss pretty heavily the last three: risk and benefits. When is it appropriate to have someone on opioids? When do we get them off of opioids? What are the best ways to do that? And then with opioid use disorder, previously known as opioid misuse disorder, and before that, opioid addiction. Those are synonymous. That's changed over time so that people with opioid disorder don't feel kind of the shame or the guilt that can come along with addiction. When we say opioid use disorder, if you think misuse or addiction, it's the same clinical presentation. So why are we here? The core statement is going to show up here. Let's go through all of them, actually. The first one, let's talk about all the things that come along with opioid use. Appropriate use and inappropriate use in its many forms. Misuse, addiction, diversion, illicit use of it. When opioids are prescribed, how do we, in real time evaluate their effectiveness and appropriateness? What's the potential unintended on underprescribing and overprescribing? And then the biggest statement at the end here is really that this course isn't to promote or discourage opioid use. It's to provide education that you can use as a smart clinician in your own practice as you see fit on a patient-by-patient basis. So this is the data up until 2018. We presented this last year. We look at, it really focuses on kind of displaying legally prescribed opioids and the increase we've seen over the past several decades, up until about 2010, 2011, and then a slight decrease. But as that decrease, what we see is that maybe patients aren't using less opioids. We also see that maybe they're just using different opioids, like illicit fentanyl and heroin. And currently right now, illicit fentanyl and heroin are cheaper to buy on the black market or illicitly than if they were to buy, sometimes cheaper than a copay, unfortunately, and sometimes cheaper than buying their own prescription on the black market. When we look at this, black are all opioids. Our yellow is our heroin use. Again, we see that go up as prescription opioids come down. Synthetic opioids, primarily think methadone. That can include tramadol, Nucynta, but for this data, really think methadone. And they did not differentiate when that's used for chronic pain versus people that are already in maybe methadone maintenance programs. So there's some mixed data there. And then as we get into the natural and semi-synthetic, that's as we get into a whole ram of legal and illegal use of morphine, codeine. If this were brought out, though, to 2020, what we would see is a continual decline in prescription opioids being prescribed, used, and misused. But we would see a huge rise in illicit fentanyl. That's been the big one the last 2 years, and also a similar trend with heroin. Illicit fentanyl, though, more than heroin. Everyone's fairly familiar with the DE scheduled drug list. I think we're all familiar with this. A couple caveats that we'll get into later. We'll spend some time on medical and recreational cannabis. Although it's becoming more popular to use medically, federally it's still considered a Schedule I chemical. And that's where we get into this big gray area as physicians and providers, where medical literature is growing, but we don't see federal regulation changing whether you're in favor or against it. It's been somewhat stagnant. The majority of our conversation will focus here in the Schedule II medications. Schedule III we're very familiar with. And then the only correction I'd make here, as in my own personal soapbox, I would consider these lower potential. I personally would not consider them low potential. I think we've all kind of seen the history with Soma that's up there, and we're all seeing the interaction that benzodiazepines have with opioids. But even by themselves, I think we all have patient experiences where obviously giving up a Valium or a Xanax is a lot higher than giving up an ibuprofen or a meloxicam. And sometimes there's clinical reason for that. Other times there's addiction potential there that we're really not looking at as a healthcare. And then I'll say lower as well for abuse. This is your cough syrups, usually Tylenol with codeine. Although lower risk than our other opioids, that risk potential is still there, especially from our chronic COPDers that may be on it. Let's get into fentanyl here a little bit. This has been the biggest issue we've seen since that 2017 data, is the illicit use of fentanyl. Heroin has been kind of riding on its coattails, but we still see way more illicit fentanyl used. There's been a couple cases here in Utah, one in Utah County, where they've even seen counterfeit Percocet that was really counterfeit Percocet, but inside it chemically was actually illicit fentanyl. We have a couple DEA agents and undercover narcotics officers in our practice, and when I've kind of run this by them, that's what they're seeing as well. I saw one about 2 weeks ago and let them know I was presenting this slide, and I said, when you're going on these undercover busts to houses, what are you seeing? And he says almost 100% fentanyl or carfentanil products. If it looks like a hydrocodone or a Percocet, they still are actually testing it. It's showing up as fentanyl. He said in 2 years he's seen one drug bust where the pills were actually, like prescription pills being diverted. The rest were counterfeit fentanyl. The big issue with fentanyl is not only how fast it acts, it has a lot of analogs that are just as scary. This number has only increased. As of 3 years ago, it was 540%. It's increased from there, and a huge increase in spike when COVID happened, which we saw that with other mental health issues, trouble getting medications, clinics closing down. Obviously, it's illicit. The illicit fentanyl and the illegal fentanyl they're seeing is stuff that's being illicitly produced. This is not fentanyl that's being prescribed to a patient, diverted from a pharmacy, or stolen from a distributor or manufacturer. The big thing chemically with this, obviously it's an opioid. Respiratory depression happens with all of them. With fentanyl specifically, especially IV forms or injectable forms, you also get thoracic wall rigidity, which clearly just makes the respiratory depression even worse, right? And so, and we've seen this clinically. I've had 2 patients in my practice that had COVID and COVID pneumonia that were admitted to ICUs. And in those cases, both cases that I reviewed, fentanyl was used IV for pain control and not propofol. And within 48 hours of the IV fentanyl, both patients passed away. And I have a huge suspicion it's from this rigid chest wall syndromes, where the handful of other patients that had propofol or were given benzodiazepines through that, we didn't see that same response. So something to keep in mind. And it's even as pain providers, when we look at how do we sedate patients in our own practice, this is one that I see in my own office, but also colleagues' offices. We see a lot more benzodiazepines being used than IV fentanyl for this reason. So, and then Dr. Romankowski is our, I mean, he's the anesthesiologist here. Any additional concerns or comments you have on that?
Well, I think with what's being sold on the street is we don't know the dose. So dose is super important when we're talking about fentanyl. And 100 micrograms, 150 micrograms of fentanyl will help through the induction of anesthesia to put a patient to sleep. These are coming into milligrams, 2 milligrams per pill. And so their respiratory depression, their apnea is almost immediate. And to reverse that, I mean, you have to be on it with your naloxone, repeat doses of naloxone. So I think that's one of the biggest things. Not necessarily that fentanyl's in there, because that can have the same effect that these oxycodone pills would have, but it's the dose that comes along with it. And some data would suggest that dealers who are selling these medications actually like when some of their patients die, because that says to the street value that this is a potent product. Someone should go there because the dealer has good stuff. When unfortunately they do it as well and die. So there's no monitoring to how these drugs are being produced, nor the dose that's involved in these medications. So it's kind of like Russian roulette, unfortunately.
Yeah, great comment. Go ahead.
Could you please describe what rigid chest wall syndrome is? I've never heard of it.
We see it more times often in very short-acting opioids, so like remifentanil infusion. Short-acting, what happens is these intercostal muscles become very rigid and tight, and so it decreases the ability for the patient to take adequate deep breaths to oxygenate.
A little bit closer.
Sorry.
Better in the back?
So I don't know how much of that you guys heard, but what ends up happening is a decrease in oxygenation because of the inability of that patient to do full inspiration expirations. So yeah, so typically what we see intraoperatively is that this will develop their CO2 will increase, and so you'll want to change up your ventilatory settings. But in a outpatient setting, it's really hard to differentiate why this person's apneic. It's likely just because of the opioid itself. In that ICU setting that Dr. Benfield was talking about, plus or minus if that was involved, we do see it a lot more with the shorter acting opioids, not necessarily fentanyl, but high dose fentanyl can cause it as well.
Awesome, thank you. Oh, go ahead. My understanding is they both can do it, but the shorter acting and higher the dose, the more likely it is to happen. From my understanding of the literature, this happens more with fentanyl use in the anesthesia setting for an OR case. It happens in pain, GI, cardiology suites when IV fentanyl is being used to induce for like mild to moderate sedation. And obviously this could happen with IV or IM use illicitly too.
Yeah, mostly when you're establishing a steady state with a continuous infusion when you see this particular.
Will the naloxone reverse both of those if given quickly enough?
That's a good question. As far as intraoperatively, we wouldn't use naloxone 4, we were able to control ventilation a little bit better and oxygenate. In the outpatient setting, that's a good question. I don't know if it will reverse rigid chest wall if it actually develops.
Yeah, it'd reverse the opioid, but if the dose is high enough, your mu kappa delta receptors may be saturated enough where it gets too little too late. And is cases where the chest wall rigidity takes time to recover even when the opioid's out of the system. So yeah, great questions. Obviously, this is not new to anybody here. The other thing we're seeing, it's being mixed with other illicit drugs, including, recreational marijuana. That's the big issue, educate our patients on. And so it gets mixed in a lot of things. It's dangerous. The dosing is tricky. It presents several heads which are hard to control. So we'll go through more in this, but a lot of today's lecture will go through risk and benefits of different opioids, long and short acting, when to start, when to stop, how do you monitor. I'm not going to belabor this. And then I'm going to turn over to Dr. Romankowski to start chapter 1 of our pain. So.
Okay, guys, can you hear me? Is this close enough? Okay, awesome. Thank you. Thanks for having me. It's a pleasure and an honor to be able to speak to you guys today. My first couple of chapters are more about the pathophysiology, a little bit about neural transmission of pain, how we get from a painful event to development of chronic pain, distinguish between acute and chronic pain, distinguish between nociceptive and neuropathic pain. Nociplastic pain is in there as well. Identify the body's homeostatic mechanisms for resolving pain, and recognize the relationship between the physical, psychosocial, spiritual health of our patients who experience pain. So, let's see here. Neuromechanisms of pain. So this is kind of a brief overview of how we transmit pain. So let's take, for instance, someone who steps on a painful tack, as we see there. We have little nociceptors in there that on the next slide you'll see kind of this neuronal soup that occurs. But the interesting part about this slide is really how we get to the brain and how we sense pain. So we step on that tack. It's a little bloody, it's not fun, and it hurts. And these nociceptors then transmit pain through these peripheral fibers. Usually the A delta fibers, C fibers are transmitting that information along this pathway, and then we get to the spinal cord where they synapse. And when they synapse, it's usually in that dorsal horn of the spinal cord. It then decussates and goes up the spinal thalamic tract up into the brain, which is what we see here. And in the brain, that's where we perceive pain. So it'll ascend up these tracts into that brain and go into the thalamus and the midbrain, the periaqueductal gray area in particular. And from that point, we're able to sense pain, understand that we're in an event of pain, and that's a complex process because it's not only this painful stimuli we're feeling, but also it's invoking parts of the brain that attribute or that we sense emotion, that we are able to perceive and process this information. The limbic system in particular at the anterior cingulate gyrus is where we have that emotional response to pain. And so we'll get into it a little bit later about the IASP's definition of pain, which is practically a physical and an emotional response. So we have to think about how our body is actually receiving this information and dealing with it. It's not only these pain signals, but our emotional response to these signals. Next part of that is there's a descending pathway that contributes to when we say, for instance, use stub your toe or step on a tack, an initial response to that is to pull back and to maybe rub that area. So what we're doing when we rub that area is causing a descending pathway to inhibit some of those pain signals. Our brain, unbelievably so, can do that with neurotransmitters as well. And that's really what that sensation that we're touching that painful foot is doing. Medications can help modulate that. So there's a bunch of areas in here where it says modulation occurs. Each one of those areas are targets for us treating a patient with pain, acute or chronic, that can be beneficial to helping that patient deal with that pain. Some of the peripheral pain modulators include histamines and prostaglandins. We have cytokines, bradykinin, substance P. Glutamate is an excitatory neuromodulator. CGRP, VIP, nitrous oxide, all of those things are released when we have a painful stimuli like that. And then in that descending pathway, we have serotonin and norepinephrine, and I'm sure all of you are familiar with that, using TCAs and SNRIs. We want to block the reuptake of those because those neurotransmitters actually help inhibit some of those pain signals from developing and becoming a chronic issue. The endogenous opioids like enkephalin and dynorphin and beta endorphin, those are all things that the body naturally releases in the setting of a painful stimuli to help also manage that pain. And ultimately pain is, especially in the acute setting, our body's natural response to protect itself. That's evolutionarily, it's if you're, the caveman walking into a fire that you've recently started and it hurts, maybe that's the message to say, okay, this is something that I need to handle with care. And so as we, evolved, it became more and more complex. This next slide is about more the mediators, kind of what I alluded to. So when you step on that tack, you see on the kind of the left side of the slide there's the injury, the insult, right? And then with that insult, we have your tissue itself releasing all of these modulators and mast cells and blood vessels. They all release this neuronal soup. And so you see this kind of circular pattern here. There's histamine, bradykinin, serotonin, prostaglandins, potassium, and all of those are released and then stimulate that nerve to transmit that information to the spinal cord up through that tract that we were talking about. Feeling physical pain is vital for survival. Pain's the body's early warning system, like I alluded to. And in this slide, I think what's important is that this transmission, it goes through a lot of different areas that can be modulated. Once again, this dorsal root ganglion here is a big area of interest for us in interventional pain because we are able to actually stimulate that region of certain spinal nerves and decrease painful stimuli, basically kind of closing up a gate of transmission for constant pain signals to travel. For instance, someone with chronic knee pain after a total knee replacement, we can do dorsal ganglion root stimulation to certain spinal nerves and essentially block that pain transmission, and patients can do very well from that type of therapy. At the spinal cord as well, a very big area for us to stimulate with neuromodulation, which is something that I'm extremely interested in. And so we stimulate with little electrodes at the dorsal column of that spinal cord up in the thoracic region and essentially block some of those pain signals from reaching the brain. So there's a lot of areas where we can intervene, so to speak. Opioid receptor locations, super important. As you see in this slide, I think it was supposed to be animated, so it's not all in your face, but really those triangles represent areas where there are opioid receptors. We see it in the brain, in the periphery, in the gut. That's why we see constipation with opioid management and treatment. We also see it in that dorsal horn of the spinal cord. So right in this region. And there's a really specified rex lamina, so it's all segmented to where these nerves are synapsing. And in the rex lamina 2 is the substantia gelatinosa, which has a very high density of mu receptors, and that's one of the targets for opioid medications. Now, another major part of where opioids are located is in the periaqueductal gray. And in this, from my family's from Cleveland, Ohio, and I'm Italian, so I'm swinging my arms around a lot. But in that perioctal gray, that's one of the main targets for us to get opioids and where we want them, because that's kind of where our brain is processing this pain. Throw it on here. Not that good with these things. In that, so the Lucus coeruleus is also in that perioctal gray region, high density of mu opioid receptors. Just adjacent to that perioctal gray is the prefrontal cortex, the nucleus accumbens, and amygdala. And the nucleus accumbens and amygdala are important because that's where we sense euphoria when we have opioid activation. And we also have that emotional reward center there in the amygdala. So unfortunately, when we use exogenous opioids, we're also stimulating that nucleus accumbens and amygdala, and that's kind of where we get into the drive for opioids in some patients and the abuse potential. So someone, say with anhedonia, who doesn't necessarily make or produce many endogenous opioids, you give them an exogenous opioid, and they have a high propensity of developing a euphoric type of state because it's something that their body naturally isn't producing. And so that's also kind of where we talk about that abuse potential. It changes how the nucleus accumbens and amygdala respond to having that exogenous opioid and the pleasure that comes along with it for some patients. And some are more, some people have a different kind of way that they process that information, and it puts them at a higher risk of being a responder and elevates that abuse potential, unfortunately. Next slide here. Types of pain. Okay, so this is an interesting slide. With types of pain, I'll just get all these up here. Okay, I think it's important to kind of define pain itself, and I alluded to it before with the International Association of the Study of Pain, or the IASP. But pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. And I wanted to read that specifically from them because there have been multiple kind of iterations of the definition of pain, and you can talk to people throughout the industry, and everyone has a different idea of how to describe pain. But this definition, I think, covers a wide breadth of how a patient actually experiences pain. And there's some additional definitions that the IASP has put into this definition, some subsets of it that I think are important. So I'm going to read those to you. Number one, there's 6 of them. Number one is that pain is always a personal experience that is influenced by varying degrees of biological, psychological, and social factors. Understandable. Pain and nociception are different phenomena. Pain cannot be influenced solely on activity in sensory neurons. Number 3, through life experiences, individuals learn the concept of pain. And number 4, a person's report of an experience of pain should be respected. Number 5, although pain usually serves an adaptive role, adverse effects on function and social and psychological well-being can be present. And then number 6, verbal description is not only one of several behaviors to express pain, but the inability to communicate does not regulate the possibility that a human or a non-human animal can experience pain. So that kind of came from patients who may not be able to speak, or our advanced dementia patients who aren't able to verbally tell us that they're experiencing pain. The IASP really wanted to define pain as an experience that anyone can experience, but it doesn't need to be transmitted just verbally. I mean, we can look at pain behaviors, wincing, grimacing, all of those things to understand that someone is actually experiencing pain. So I thought that was important. Now onto the types of pain. Kind of look this way. We have three different types, but then there's mixed types at the end. But nociceptive pain is how you would think about an inflammatory type of pain, much like that tack that we stepped on in the earlier slides. It's in response to an injury of stimuli, typically acute. Post-operative pain can be seen as nociceptive pain. Sports injuries, arthritis, knee pain, sickle cell disease, mechanical low back pain. And when we get into mechanical low back pain, as you see in the nociplastic section, it says non-specific. We see a lot of these kind of overlapping, so it's really hard to put low back pain into those categories. But the next one that we should talk about is neuropathic pain, because we probably see this a lot in your clinics. This is pain that develops when the nervous system is actually damaged. It's typically chronic. So examples of that would be postherpetic neuralgia, trigeminal neuralgia, diabetic peripheral neuropathy, CRPS, and neuropathic type back pain, which we can see in someone who's had a failed back surgery or post-laminectomy syndrome. They can develop a neuropathic component to their pain. In that middle section is nociplastic, and this came from the IASP as well, because there's some that either overlap or just don't fit into these categories as well as we would like them to. And this is pain that arises from altered nociception. And this is typically chronic. And the examples provided by core REMS are fibromyalgia, IBS, nonspecific low back pain. I don't know about that. But those conditions that you see with these patients where you're like, I don't think you should have pain, but you have pain, and I need to figure this out somehow, some way. That gets into more of that nociplastic type of pain. And then, of course, at the end, mixed type, so nociceptive and neuropathic pain, primary injury that then develops into a chronic pain issue. These just kind of showing that they overlap. The next thing that we should talk about is the patient holistically. I mean, I am a big believer in the biopsychosocial model as well as that spiritual connection in the context of pain. We are human beings, and I think that pain not only affects, our physical state, but also our psychological state, mental state, social setting, spiritual life. And so we really need to incorporate more of a biopsychosocial model when we're seeing a patient that's suffering from pain. And these are just some of the examples. I won't get too far into it, but in the psychological section, there's catastrophizing and depression. Anxiety and depression can predispose a patient to developing chronic pain. So these are areas that we really need to focus on when we're doing our assessments. That spiritual context, social context, I see a lot of patients, they want to be at work, but they can't because of their chronic pain issue. So it's not just, I broke my leg hurts, I need it fixed, and then I'm back. Unfortunately, patients kind of go down this route where multiple aspects of their lives are affected. So there was an interesting study, I think in 2017, by a group of Spanish doctors that really got into is empathy important when I'm seeing a chronic pain patient? And in fact, it is. So the patients who responded better to their treatments, those with chronic pain, noted remarkably that if they had a provider that showed empathy, they had better outcomes. So I think, at the end of a long day when you're seeing 30, 40 patients in clinic, taking that extra 5 minutes to empathize with a patient with chronic pain is super important, and we have evidence to support that. This slide, just talking about pain catastrophizing, I think that psychological aspect that's involved when someone is dealing with chronic pain is huge. And fortunately, in the clinics that I work in, we really try to do an interdisciplinary approach. And we have 3 psychologists right now that focus primarily their practice on chronic pain population. And so we try to incorporate that into the treatment of, I'd say, what would you say, Carrie? 70, 80% of our patients at least. If they're open to it, we get them over to them, because I think there's a lot to be said about how an individual deals day in, day out with their pain. And there might be those underlying mental health issues like depression, anxiety that are kind of underlying all of this and overlapping their ability to function in that painful setting. So when you're talking to a patient, I mean, listen for rumination, feelings of hopelessness, anticipation of negative outcomes. Are you avoiding activities because you fear pain? So that pain avoidance, that fear avoidance that we see, all things that can kind of clue you into how this patient's actually functioning. Chapter 2, terminology. This goes over some kind of basic things that Dr. Benfield already spoke about, but I think really the main driving point is that language matters. How we talk to our patients, how we talk to our colleagues, how we talk to our loved ones, all matters. And there's a nice quote here: if you want to care for something, you call it a flower. If you want to kill something, you call it a weed. And so, we're getting away from using some of these commonly used terms, such as addiction, where we prefer to address it as a substance use disorder, as proposed by the DSM-5. Drug seeking or aberrant problematic behavior, I wouldn't say that to a patient. Well, aberrant sometimes I do say, but that's kind of in that context where I have established a good rapport with a patient. But if I do see those behaviors, I'll usually try to address it as maybe we're not using the medication as it's prescribed. Let's talk about how these medications are being used and what's appropriate and what's not. Try not to call a patient an addict, a person with a substance use disorder. This is a disease, and it's a disease process that can be treated. And we need to make sure that we are empathetic and compassionate to someone suffering from this. Clean or dirty urine. All urine is essentially dirty, right? Maybe pretty sterile, but dirty. But really what we're looking for are positive results when we don't think there should be positive results, or negative results when we don't think there should be negative results. So I think using that terminology is a little clearer. Some other words: misuse. That's really when a medication's used in any other way than it was prescribed. Abuse, when you're using that substance without the proper intent. So you're using it to, say, for opioids, get high or have that euphoric feeling. Tolerance is something that develops when we provide opioid medications. Our body becomes more and more tolerant of that, and we need to increase dosages typically to achieve the same result. Dependence is when that organism only functions normally in the presence of that substance. And then we can drop down and get into withdrawal. So if someone's dependent on that medication and we take away that medication, or they do not continue that medication, they can go into a state of withdrawal, which is uncomfortable symptoms, psychological changes, and that, like I said, comes from a decrease or an abrupt stop of a medication. And then diversion, any transfer of that medication, that legally controlled substance, from one person to another. This could be even someone in the clinic. We would call diversion someone taking medications from the clinic and using them for themselves, passing over to a family member. Oh, my uncle hurt his arm, I'm going to give him one of my opioid medications to help him. That's diversion, unfortunately. It's illegal. One of the other terms that I hope we're all familiar with is MME, or the morphine milligram equivalent. And that's a standard opioid dose value based on morphine and its potency. So this is how we get 1.5 milligram morphine equivalents of oxycodone to 1 milligram morphine equivalent of morphine or hydrocodone. And so we use these conversion tables to help us when we're doing opioid rotations, when we're tapering medications, when we're switching over to, say, a buprenorphine type product. So super important that we're all familiar with MMEs. And then chronic non-cancer pain is any condition that lasts greater than or equal to 3 months past the time of normal tissue healing in a person that doesn't have cancer. So how is pain resolved? Well, that's a good question, because there's a lot of different ways that pain can be resolved. What they really want to focus on in this, from the core REM standpoint, is determining elements of a patient's history and physical exam needed for diagnosis of that patient in pain, and then identifying key elements of the PDMP for formulating a treatment plan. So when I see a patient, I work in chronic pain and interventional pain, so a pain assessment is huge for me, and I really go back to med school and I do an old carts, if you guys remember that. So I'm looking at the onset of someone's pain. When did it happen? Is this 3 months ago, 3 years ago, 30 years ago, 3 days ago? That gives me a good kind of starting point. Where is your pain? Is it diffuse? Is it all over the place? Is it specifically in one spot? When does it occur? Does it occur all the time, just when you're breathing, just at night when you're lying on your shoulder, on your hip, things like that? The intensity of the pain, very important for me, because someone who walks into my clinic completely happy, but then tells me they have an 8 or 9 out of 10 pain, that doesn't line up. So I need to take what that, you're laughing because it happens all the time, right? You need to take that into account with how that patient is presenting on a physical exam versus how you see them interacting. And all of those things kind of come into your overall assessment. Not to say that that pain isn't real for them, but their scale might be very different than what an actual pain scale is there to tell us. And then there's that other patient that says 2 out of 10 pain, but is hobbling, wincing, can barely get out the door, right? So really you're taking in a lot of things outside of just a numerical pain scale to gather that information. And what's the quality of pain? Is it burning? Is it neuropathic? Is it numbness, tingling? Is it sharp shooting? All of those things super important to help us kind of key into what type of pain you're experiencing and how are we going to best treat this. What relieves the pain? Anything in your life that you do day in, day out that seems to provide some sort of relief. What things exacerbate that pain? Is it going upstairs? Is it eating a certain food? Is, the list goes on. So we need to know what is causing an increase in your pain and what helps relieve it, because that can help us on that path. If someone says movement helps me, then I'm definitely thinking that physical therapy might help you. Where in other cases, physical therapy might not be my first thought of how we're going to help treat this patient. What are the effects on pain on physical, emotional, psychosocial? So I do want to know how this is affecting your life. Is it affecting your sleep? Is it affecting your relationships? Did you just recently get divorced? All of these things help us to form a better picture. And then what's your level of function, really? Because ultimately, pain's inevitable. We all live with some degree of pain, whether it's tolerable or not. But does that inhibit your functioning in daily life? And those are the things that I really want to know. Can you work? Or is your pain so bad you're out of work? Those type of things. Always getting a good past medical history, treatment history. Were you recently diagnosed with cancer? I want to know that. Did you recently have a family member that you lost? That's part of that psychological situation. What pharmacologic strategies have been effective for you? What have you tried? What are you currently on? All important when you're working up a patient. The non-pharmacologic, have you tried physical therapy, acupuncture, massage, cognitive behavioral therapies? What have you done outside of a medication that has been beneficial for you? Relevant illnesses, kind of touched on that. COVID, we're seeing, long COVID type of symptoms. I just had a patient the other day, came in 3 months ago, diagnosed with COVID. Since that time, never had multi-joint kind of inflammation and pain, and now significant. So we're doing a little bit of a workup there. I don't know the specific facts about what we're going to see long term, but I do know that I am seeing patients who are having effects from COVID. So that's something to keep in mind with patients that have been recently diagnosed or within the last 2 years have had COVID. And then in our clinic, and I'm sure in a lot of yours, what's your current opioid use? They might be coming to you on a significantly high MME, and you're wondering how you got to that MME. Or they're on a very low dose, and when did you start it? Is it even helping? Have you tried all of these other things outside of opioid medications that could be beneficial for you? One of the things that we always want you to do is query the Prescription Drug Monitoring Program, the PDMP. And in Utah, it's through DOPL, the Controlled Substance Database. And on every one of my patients, if they're on an opioid or not, I'm looking because I want to know if there's anything popping up on there that I should be aware of. And documenting that as well, that I've checked the PDMP. And I think it's very important for all of us to be doing that because doctor shopping's real. Recent events in a person's life that you weren't aware of are real. And so getting these medications and having them documented in our database can be a very, very helpful asset when you're going through your plan of how you're going to either take over that medication, transition, or decide not to continue that therapy. So a little bit more on the PDMP. These are state-run electronic databases. I would assume you're all familiar with it, but we kind of go through this a little bit. It provides full accounting of controlled substances filled by that patient. Not all the time are they as up-to-date as we'd like them to be. For the most part, I see in Utah that within 24, 48 hours of a patient filling a prescription, it's usually there. In Florida, where I was before doing training, it was a couple of days, maybe up to a week before we would see the site getting updated. And so there's that variability. If a patient just saw, say, a dentist had a tooth procedure, got a new oxycodone, and you're prescribing, Percocet as well, then you really want to be on top of that because dose matters when it comes to respiratory depression, overdose, and death. So really being upfront with patients, I checked this. This is concerning to me. What happened here? I think having that conversation is very important. Nearly all of these databases are 24/7. I wish that they were kind of a nationalized system so that you could see if patients from Wyoming or Idaho were filling their prescriptions there and then coming down. It was a big problem in Florida. Imagine that, people coming from filling prescriptions in Georgia and then coming over to Florida, getting prescriptions, and so a lot of doctor shopping there. And so at least you have the ability to talk to the PDMP of each state and you can request privileges to view that. Benefits, we talked about it. It really helps see if there's any aberrant behaviors, any existing prescriptions that you didn't prescribe. And if you've signed a medication management agreement in your clinic, that patient, at least in ours, in my clinic, states that you cannot receive opioid medications from other providers. You need to contact our office before any of that is approved, and certainly before you take it. Obtain a complete social and psychological history. I think we've I won't belabor this point, but really mental health is super important in the chronic pain population, predisposes patients to developing chronic pain syndromes when you have underlying mental health issues, previous abuse, depression, anxiety, all of those things are predictors of chronic pain. And then we take it all together. We do a physical exam, and we want to really be directed during our physical exams, but also be very aware of the setting. Like we talked about, that patient that walks in is completely fine, but then says, 10 out of 10 pain. The exam might not line up, and there might be some exam findings that you wouldn't expect. And so I think doing a very thorough physical exam, targeting your system, is always important in any patient that we see. And then coming down the line, if they don't already have imaging, I see a lot of, low back pain and no x-rays have been done, no MRI, they have a radiculopathy. I want to see that information. It gives me a really clear picture of how I'm going to take the next steps in treating this patient. And then there's a ton of different pain assessment tools. In my clinic, when a patient comes in, if I can't get them into psychology quickly, then I'm going to do a COM-17 on that patient just to assess their current use of the medication and if there's any underlying misuse or aberrant behaviors that are found. And then that puts me into a risk stratification. Is this person low risk for opioid abuse or misuse? A moderate risk, a high risk, someone that I need to be doing drug screens on more frequently or seeing in clinic more frequently, not doing 3-month prescriptions, seeing them every month or even every 2 weeks because there's a high risk to those patients sometimes. Some of the pain assessment tools that we do use are the Brief Pain Index, the 5 A's. So analgesia, are you getting good analgesia from the medication? What's your activity? Adverse effects that you're seeing from the medications, aberrant behaviors, or the affect really of that patient in front of you. The Promise 10 is something I also use to kind of monitor patients throughout their therapy. This gives you a good estimate of kind of the global physical health of that patient and also the global mental health of that patient. And you can track those numbers. It's some objective data that can help you support or refute what you're doing for that patient. Because if their PROMIS 10 isn't improving, then we need to think of different ways to help target this pain and treat it more appropriately. One assessment in the advanced dementia population is the pain AD, and this is kind of more that nonverbal way of getting information about how much pain this patient's in, so that you can really treat them as empathetically as possible. And with that, I'll turn it over to Dr. Minori. Thanks for your patience with the fumble there. What's up?
Perfect. Can everyone hear me, or should I move this up? We're good? Okay. All right. So I think after this section 4, maybe we may take a little pause to see if anybody needs to just get up and stretch their legs. So I'll get through my section here, and then we can do that if we need to. My chapter 4, creating the pain treatment plan. You'll notice throughout a lot of this that we build upon each other, so you may be hearing a lot of things a couple times, but that's good. Some of the learning objectives specifically for this chapter, we want to focus on applying assessment results to create really individual treatment plans for patients with functional goals driving those treatment plans. We want to identify evidence-based medicine and these non-pharmacological options and non-opioid approaches. We're going to align treatment approaches to those specific types of pain that Dr. Romankowski explained earlier. We want to correlate precautions and considerations for opioid use with special populations. We want to identify common adverse events and drug interactions with opioid use. We're going to identify the characteristics that influence the choice of a specific opioid and demonstrate the ability to document patient care using informed consents and the PPA, the patient-provider agreement for pain patients. So this next slide, I mean, it's very kind of general, but I really like it a lot because it stresses the components of a multimodal treatment plan for pain, which is really so very important. You really want to develop a comprehensive treatment plan. It should be developed and customized to the patient's individual needs. The treatment plan should include the goals of the treatment, the types of therapies planned, and an explanation to the patient and healthcare team what their roles are and their responsibilities. The goals of the treatment should be based on expected outcomes of pain reduction, but more importantly for me, as a rehab doctor in background, is improved functional outcomes. Impaired from pain. So your activities of daily living, the quality of life is really important, not just a pain score reduction, a number. A multimodal plan it should include non-pharmacological and or pharmacological approaches. And the idea is to establish the cause and type of pain, initiate non-pharmacological or non-opioid therapies first, and then regularly assess all the time. The overall treatment approach for the plan should be well documented, like we talked about, in the patient record. And we really want to place emphasis on these terms, which I like all of them: advocacy, empathy, collaboration is very important, compassion, effective communication with every patient, and evidence-based practices. And the point of all of this is to really keep our patients safe. So the next slide is, we're going to just kind of get everything up here so you can see it all at once. So it's basically a diagram details multimodal approach here. So we have all the different treatments in the big boxes there, and how those approaches impact the pain continuum, which implies successful tools and interventions from all 4 of these categories, not relying on 1 or 2 things. It just doesn't work that way. So these include a lot of different types of treatments. I think of them as passive and active treatments for patients. A passive, like a medication or an injection, and an active is participating in physical therapy and establishing a good home exercise program. So it doesn't work if we rely just on active or passive. We have to combine everything. So evidence-based non-pharmacological treatments, there's quite a few things here to consider. In some, you may have more access to others, and patients as well. Obviously, we may have more access to others than all of these listed, but regardless of the type of pain, non-pharmacological approaches should always be considered. These approaches have been found to be effective alone, but more important as a comprehensive plan, management plan, particularly for musculoskeletal pain and chronic pain itself. And actually, there's options that we've listed here are all worthy to consider, but there is a lot of evidence to support efficacy for yoga and Tai Chi, actually. There's a lot of Cochrane reviews and things that do support that as a really good therapy. So I'm going to go through this again, another animated slide here, and this is one that Dr. Romankowski touched on, but we're going to look at it through a different lens right now. So basically, these are used in conjunction. These are all different types of kind of medication, pharmacological treatments based on the type of pain, and they should be used in conjunction with non-pharmacological modalities. These aren't listed, they're listed in alphabetical order. It does not imply preference though, so be aware of that. But really you want to continue effective non-pharmacological options here. We really should consider all pain management options and prescribe opioids only when non-opioid options are inadequate or when the benefits of using opioids are expected to outweigh the risk. So first here with the nociceptive and inflammatory, it's really, these are things we consider from an interventional strategy like nerve blocks, but really topical anti-inflammatories and things can be really helpful for this in the acute setting. I use a lot of compounding type medication as well, and working with certain compounding pharmacies to really individualize a kind of cream for a patient based on their type of pain, which can be really helpful. And then also with nocioplastic. So Dr. Romankowski touched a little bit on this earlier, but it's really a multifocal pain and it's widespread. And the big thing is it augments the CNS pain and sensory processing. So you actually have altered pain modulators in this population. And one specific is people with fibromyalgia. They have reduced mu receptors availability within the regions of the brain that normally process and dampen pain signals. So really you want to avoid opioids in this classification of patients if you feel that's their primary pain generator or type of pain. And then we also have neuropathic. So, antidepressants, SNRIs can be really helpful for this. Interventional strategies such as nerve blocks, we often try to rely on from an interventional standpoint. Let's see here. Okay. So this is another slide Dr. Romankowski went over in a lot more detail, but it complements points made earlier about the nature of peripherally mediated pain. And of course, always the central nervous system is involved to some extent, but when pain is caused from like a recent surgery or a peripheral nerve injury or insult, early initiation of anti-inflammatory medication and non-opioid options such as topicals like we talked about can be really effective if it's caught early. So drug characteristics to consider before prescribing. I think on this slide, it's a busy slide, there's a lot going on. It just says we should take into all characteristics into consideration. And most of these apply to any drug, although the ones towards the bottom are a little bit more relevant to opioids itself. And at the bottom there, the FDA has compiled kind of prescribing information for all opioids on the website shown below. So that's really the take-home point of this slide, is that website at the bottom there, I want to point out. So consider an opioid. We really consider all pain management options, that's the theme here, and prescribe opioids only when non-opioid therapies are if they're inadequate, or again, the benefits of an opioid may outweigh the risk. But when you're doing that, you really want to begin as a therapeutic trial. So you're trying to build in the expectations and understanding that this is kind of a trial that we're doing. We'll try the medication. If it doesn't work, we may have to change or stop the medication because we really want to promote benefit of using that medication. So for me, when I'm trying to determine that, I really want to look at what the patient's goals are. So what are we trying to achieve and document that? And that for me, that's activities of daily living, functional improvement, quality of life. And they're specific to the patient. It's not a pain score, a pain number. I actually kind of take those things out of my room because I don't want that to be the focus of their pain. I want to show them that they're providing functional benefit with the treatment that we're doing. Decreasing a pain score for me is just not good enough unless I'm showing they're functionally gaining benefit. So opioid misuse risk assessment tools here. There's a list here and they're broken up into 2 categories. So it identifies contemporary commonly used tools to assess risk of misuse or abuse. And I want to make a point that there is not one screening instrument that can reliably predict those patients who are not suitable for opioid therapy. Presently, a combination of strategies is recommended to stratify risk and identify and understand aberrant-related drug behaviors and tailor treatments according to those behaviors. So really, for all patients, you should be checking the PDMP. For chronic pain patients who opioid therapy may be used a little bit longer, we also need to get urine drug screens as well. So specifically here, this next slide looks at the ORT, the ORT. This slide is actually the updated version of this from 2019. There was an older version, but the ORT, just briefly here, it's a 9-question measure to classify patients as either high or low for misusing opioids prescribed for pain. And highlighted up there on the right, substance use disorder history. It does not prohibit treatment with opioids, but may require additional monitoring and expert consultation. And we have pain psychologists in our clinic. And one important study that was done in 2019, so it's a little bit before the ORT came out, is they looked at the ability of all these screening tools to predict aberrancies, so overuse of medication, drug use. And they looked at each one in their sensitivity. And basically, the take-home point of this study, it was 48 patients at a pain management center. The highest sensitivity from one of these screening tools alone, used alone, was about 0.72 to 0.77. When you combined it with a clinical interview, so you used a tool plus a clinical interview from a pain psychologist, the sensitivity went up to 0.9%. So really, if you have the ability to do that, that's definitely what I would recommend. But not all of us have access to psychologists. So opioid side effects and adverse events, I know probably a lot of people in this room know this list very well, but opioid analgesic medications carry a lot of risk with them, not present with a lot of non-opioid analgesics, specifically the risks, like Dr. Romankowski talked about, going over those terms, addiction, abuse, misuse, but really respiratory depression, overdose, and death. The ones on the left side, you can see our side effects, and then adverse events are listed on the right there. And it is our responsibility to be knowledgeable about these. And we also have to explain these things and educate these to our patients here. So opioid-induced respiratory depression. This is looking at this one specifically. It's the #1 most life-threatening, obviously, situation with opioids. Education is huge. Educating and reiterating not to swallow tablets, take the tablets as prescribed, swallow them, don't crush them, break them up, and co-prescribe naloxone. Big populations here to be considerate for our elderly population. Also, if we're given with other drugs that depress respiration, benzodiazepines, and patients who are opioid naive, just starting, or if you're escalating dose or increasing dose. Also, I have concern too when we're changing from different opioids. So if one's ineffective and we want to change to another one, that is a time where spidey sense is very high and we're kind of checking in with that patient very frequently to see how they're doing. So transdermal, transmucal, and dosage forms, there's a lot of specific things for this type of opioid form here. One of the things at the bottom that's important that you be aware of is exertion or exposure to external heat. A lot of our patients are using heating packs all over, so we have to be careful with them using those over the medication that are in this form. So no drug interactions, the pharmacodynamics and pharmacokinetics. So this slide talks about the kinetics, so refers to basically movement of the drugs through the body, and then the dynamics is really the body's biological response to that drug. So some of these I want to touch in here, like the MAOIs, they can cause serotonin syndrome, so tramadol, very important one there. Also with methadone, prolonged QT syndrome, so you really want to be checking EKGs periodically as well. The extended release or long-acting products can rapidly release. We call that dose dumping when used with alcohol. And then opioids, you know, if you're also having, it can reduce effects of other medications such as diuretics. There was a Cochrane review that looked at kind of the risk profile of different medications, and they ranked methadone as one of the more higher risk type of medications in that review itself. And there's reasons for that there. So looking at opioids again, the enzymatic interactions here really with the liver system, the CYP450 here. This reiterates again the importance of knowing product-specific information before you prescribe. Consider the effects of other medication a patient is taking. And you really want to just kind of be aware. There's also, on this slide, they mentioned too here, the genetic and phenotype variations. So pharmacogenomics is something that's out there too, but there is a lot of payments from insurers can be extremely variable with this. So just be aware of that there. It's also, hold on one second here, I'm sorry. No, with this, I want to make a point on this slide as well. It doesn't really talk about this that much, but it's really important to let a patient know, and when you're educating, that any changes in other organ systems that process these medications into their active forms, such as the liver and kidney, can change those levels in their body without them even knowing it. So this is a very important point that Dr. Ockey stresses a lot when he's educating patients, and I've kind of used this all the time, and it always turns a light bulb on. The eyes always get bigger when you mention that. So they can be having an insult to their kidney or liver. It's not functioning properly, may not know, and that will alter the metabolites in the body and can produce an adverse event. So please be aware of that. So drug interactions, we talked about these into 4 categories here. CNS depressants, so increased risk of respiratory depression, we talked about that. Sedation, coma, partial agonist or mixed agonist, antagonist. So there's like buprenorphine. We got to be careful with use of full agonist opioids as well with that. Skeletal muscle relaxants. So there's actually only one muscle relaxer that works on the sarcoplasmic reticulum. The rest are depressing centrally. So, you know, the term's a little misleading, especially to patients if they don't know that. So that's something else to educate patients on. And then anticholinergic medications, of course, urinary retention and constipation. So within this chapter, we're going to just touch on special populations of patients. The first, really, a very susceptible population are older adults. Basically, the complexity of managing care in older patients with persistent pain does call on a multidisciplinary approach. Older patients have medical problems that can increase the risk of adverse events. Respiratory depression is more likely. Elderly patients we know, are cachectic a lot of times or debilitated, and they have altered pharmacokinetics due to poor fat stores, muscle wasting, and altered clearance. So we want to be careful with that when prescribing these medications. And also, too, cognitive changes, fall risks are really important here when prescribing. And I always will consider talking about a bowel regimen with a patient who's elderly on an opioid too. So women with childbearing, it's important to know that the reproductive plans of a patient, you should be aware of that, contraceptive use, pregnancy intent or status, and breastfeeding plan of these patients. The American College of Obstetrics and Gynecology recommends universal drug screening for substance use as part of their obstetric care and should be done at the first prenatal visit. Women using opioids on a daily basis, they actually do recommend, and that's in the slide here, methadone or buprenorphine. I'm kind of a little bit more on the buprenorphine side myself than methadone, just because of a lot of the issues with that medication itself. Managing pain, let me go back, I'm sorry. So managing pain in pregnant women can be challenging. It affects both mother and fetus, so potential risks during pregnancy for the newborn. We look at low birth weight, premature birth, hypoxic ischemic brain injury, neonatal death, prolonged QT syndrome, neonatal abstinence syndrome, and then opioid withdrawal can be expected in up to half of newborns with opioid-dependent mothers. Children and adolescents, The safety and effectiveness of most opioids in the pediatric patient below the age of 18 have not really been established, and most of these agents are not indicated for pediatric population. A lot of the studies that were done, the non-clinical studies examining opioid use in children, they focus on kind of safe use as an inpatient setting, not an outpatient setting. And indications for opioid use are primarily with life-limiting conditions. Relatively few pediatric patients with chronic pain due to non-life-limiting conditions should receive kind of long-term opioid use. Kind of other populations, there's a list here. So, I mean, people with sleep disorders, opioid sleep, like OSA, we don't want to use opioids as a sleep medication, a sleep aid. Be very cautious with that, especially if a patient says, oh, I take it at night to help me sleep. Just pause there for a second and ask them, what do you mean by that? Is it just to help us sleep, or is it actually I have pain at the end of the day when I try to lay down and sleep and it's my pain that's keeping me up? Just make sure you pause there and get that information from them, okay? The problem with pain and sleep is it's complicated because opioids can fragment sleep or break up the normal sleep cycle. So there's also this kind of ongoing process of the opioid for pain, but also disrupting sleep. And if you have pain, your sleep's disrupted. So it's important to educate a patient on that. Dementia or impaired cognition, I think John talked about this a little bit. Pain evaluations should still be performed, even though they may be a little less reliable. Maybe it was Mathew. Pain must be anticipated in that population. It may manifest as kind of a twinge, or you push on an area and that's how you're gauging their pain. They may not be able to actually tell you or communicate with you. Another population too, with obesity, I think is interesting because increased levels of cytokines, right, interleukin-6 specifically, can lead to increased inflammatory markers or inflammatory type pain. And a lot of these cytokines, especially IL-6, is found in adipose tissue. So kind of the more you have, the more inflammatory markers you have. So I often tell patients we're always looking, on a good weight program or diet, because it obviously takes pressure off your spine, your back. It keeps you in a better sagittal balance as well. But it is directly impacting your inflammatory response as well, too. So that's another kind of important point. Again, I talked about renal impairment and hepatic impairment with changing metabolite levels in the body. So be very aware of that. Aware of drug interactions that can develop serotonin syndrome is important there too. So like SSRIs, tramadol, TCAs. The CDC recommends avoiding prescribing benzos. I think we all kind of know that. And in Utah too here, if you have a patient who is on a benzo and you are prescribing, it is strongly, strongly recommended to contact that provider who may be prescribing the other medication and kind of have a discussion with them and maybe try to formulate a plan. I know that's not as easy in your day-to-day, but it is very, very important. End-of-life populations is another population on this list here. Really for that population, for me, when I have it, I want to involve hospice and palliative medicine specialists as soon as I can and identify that for their support as well. Informed consent. So, when initiating a pain treatment plan, you want to confirm patient understanding and informed consent to establish, the following here. This is a general consent approach for kind of any treatment. Basically, you want to discuss alternatives, pros and cons, uncertainties associated with kind of the decision to start an opioid, assess patient's understanding, and explore patient preference. Risk benefits are not all the same for every opioid itself. And then the PPA, the patient provider agreement here. This is kind of this lists the most common components of the PPA. It's a pain contract or kind of controlled drug use agreement is what we term it as, and it should be in place before the first opioid prescription is given or written for. You want to review for compliance and understanding and document at regular visits. The way I explain the medication management agreement for one of the patients is Expectations. Expectations are very, very, very important to be set up from day one. And this agreement really outlines my expectations as a provider prescribing this controlled substance. So what my expectations are for the patient, but also just as importantly, it does outline what the patient's expectations are of myself prescribing the medication. So it's a two-way streak, or that way. And that's how I kind of explain it there. Okay. So this was another slide here too. I think I rolled through another one here. So this is really reinforces kind of the expectations there. And then any of the behaviors merits investigations. So this is a tough one. So this is always a hard thing. I think we all have difficulties with this when there are aberrancies or aberrant behaviors, and how to kind of set up stringent guidelines to alter prescribing, or have a conversation with the patient as to why we can't continue to prescribe. I would just say it's really important to think about this before you have to actually do it. So really take some time to go through and develop kind of protocols, put protocols in place for yourself. But the hard part is because it's individualized a lot of the times, and it's not always necessary to dismiss or fire a patient with one bad move at the beginning, and that also depends on what it is. But I would hesitate to jump to just dismissing and firing a patient for one aberrancy, because that can create a lot of issues for a patient, and it's kind of better to keep a big hug around them to get them through that. But there are times when the agreement is broken, and as a clinician, you do have to kind of protect yourself as well, and your ability to continue to practice medicine. Okay, so that takes us into chapter 5, and I think this might be an okay time if you'd like to kind of stand up and stretch your legs a little bit and maybe use the restroom. Yeah. Did you have a question? Yeah. Oh yeah, dantrolene. Well, it's not necessarily safe. It's just the only one that actually works on sarcoplasmic reticula and kind of blocks the muscle spastic that happens there. Dantrolene. It's not one that I commonly use. I use that more in the rehab setting when I was doing general rehabilitation. But it's important. A lot of patients think they work, it relaxes my muscles, but actually they all sedate you centrally. They work centrally to sedate. They're like, well, why is it a problem that I'm on an opioid and a muscle relaxer? It works on the muscles. This one works up here. And then I have that conversation with them there. So, I'll take. Yeah. Yes.
Hospice.
They don't.
Like a hypocrite as a pain doctor making you sit all day. It's one of the worst things besides smoking. So we're going to get in now to how do we manage patients on opioids and the caveats of that. And there's a lot of it is, like we all know, medicine's equal art as it is science. And I think opioids fall into that category. It's a lot of interpersonal relationships with patients to get that kind of qualitative data from their life to see You know, they trust them, reliability, medical evidence to back up. So we're going to do a lot of that. So I'm not one to read off all the bullet points. If I miss a bullet point that's interesting to you, raise your hand. The big thing with initiating opioids I want to get at, number one, I won't say never because never makes you look stupid, but rarely ever initiate with a long-acting opioid. The caveat to that, though, I would say is some of our buprenorphine products coming out. There's people and buprenorphine is not marketed as a long-acting opioid, but its duration of action is long-acting. So Belbuca, Subutex, Butrans is a 7-day patch. It's the equivalent of long-acting. So I think there's fair game for that. These slides are approved by Doppel. I'm going to put in my opinion and my 2 cents. Feel free to disagree with me. Obviously prescribe the lowest effective dose with minimal side effects, but maximal benefits, pain and functional benefits. They say be careful increasing the dosage above 50. I would say be careful in dosing above 20. When you look at data on milligram of equivalence, as you escalate, when you get above 20, it's between 2 and 5 times the risk for an overdose or death. When you hit 50, it becomes 10. When you hit, as you get above 90, it's, I think, 18-fold, depending on the medication. So really, I'd be careful above 20. And above 90, I really try to avoid at all costs with a couple scenarios: cancer pain, end-of-life pain. And I think we all have in our practice people, if there's any surgeons here, this is not personal, people that have maybe seen one too many surgeons or one too many interventional pain docs like me. And they end up, nothing works. They may have liver or kidney issues where they can't take other non-opioids. So there are some caveats in that, but they're rare. Obviously include instructions on that medication and how it interacts with other medications they may be on or other medications that maybe you've seen them on in the past. All opioids can react differently on the patient. And I'll go into another story of a patient that kind of surprised me recently. Dr. Minori talked about the PPA, which is now more common as a medication management agreement, MMA. That's an agreement between you and the patient on your specific expectations for them on opioid therapy. They're fairly common, but again, it's between you and them, so you decide what goes in that agreement. And our office uses it not to enforce, but to educate. I kind of see it the same way that I use a consent form for a procedure. This is what I hope it will do for you. This is what we want to watch out for. And this is where I'm going to pull this therapy back. Just like if I was doing an epidural and a patient didn't stop their blood thinner, I have an obligation to do no harm. It's not personal. I'm going to pull the epidural back today. Just like if you're overtaking your opioids, I'm going to pull it back and we're going to reevaluate. I rarely discharge patients unless they're violent or aggressive with my staff. That's, for me, I don't care who you are, you treat my staff poorly, you threaten their safety, it's unprofessional behavior. I do have a lot of patients I no longer prescribe opioids to, and my door's always open for them to come in for other treatments, and most stay, which is nice. When you prescribe an opioid, they always come in 3, the opioid, the naloxone, and the bowel regimen. I would do that for medical safety. I also think it's a smart move medical legally. I prescribe my naloxone every year. It really is a 2 to 3 year medication. I do that because every January, my chronic opioid patients, I see them throughout the year, but January is my trigger to sign a new MMA. Let's reevaluate their mental health and risk and do naloxone. That's, you guys, we all do a little bit differently. The goal is figure out a system and remember it. Protect your patients, protect yourself. Always reevaluate the risk. Here it says 1 to 4 weeks. If I start an opioid, you know, when I was an intern, I was taught to never pull the Foley catheter on a Friday night. So I never write opioids on Thursdays or Fridays for a new patient. If they're going to do it, they can think about it and come in on a Monday so I can call them or see them before the weekend's over. And that's just makes me sleep better at night, decreases my gray hair count. And then here it says reevaluate risk and benefits every 3 months. I think you should do it every time you see them. I had a lady, when I moved here about 3 years ago, She was on Norco 7.5s twice a day for some pretty severe chronic gout and really severe neck pain, status post multiple cervical fusions. Very stable, low risk, blood pressure med, and ibuprofen. It's all she was on. Everything was going great. I got a phone call on a weekend from one of the internists that she had overdosed on her Norco. And we had been talking about getting her off it anyway, but 2 Norco tablets a day, under 20, safe. We still educated her. Her husband served her divorce papers. And so she went to a park, and that was her answer for ending her life. If you're on an opioid, you can always overtake it, despite the risk, you know. She's still with us. She's good. She's okay. She's on a Butrans patch now, and she's happier and she's better. So the opioid plan, so pick a functional goal. What does the patient want to do? I have a lot of my 70-plus-year-olds. They want to be in the yard. They have a certain distance they want to walk each day. I have one guy, he wants to hike Mount Timpanogos at least halfway every year. He wants to ride his recumbent bike. She wants to be able to take care of grandkids. A functional goal that's meaningful, that you can somewhat gauge on conversation. We set 3, I think just 1 to however many you want. If they meet the goal, maybe it's time to come off the opioid. If they can't meet the goal, maybe it's time to add something else. Occasionally, it's time to go up on the opioid. Always evaluate bowel function, always evaluate opioid risk, and then what gets missed a lot, though, is the endocrine dysfunction. Osteoporosis, erectile dysfunction, weight gain. There's a whole laundry list of stuff. I know I'm trying to get my own practice to have a more primary care approach to pain. So the patients that I'm managing on opioids each year, I could also do either team up with the primary care doc or myself, order a lot of these labs out that aren't just in the CBC or a CMP every year, that we can really look at and see if they're causing long-term effects. But moral of the story, evaluate, evaluate, evaluate. The prescription, the PDMP is one of the most underutilized tools. Utah, I think Dr. Romankowski mentioned it, Utah is really good. So this is the 3rd state I've worked in. I had my own private practice in San Antonio, and then spent a lot of part of my career at military hospitals in San Antonio and Kansas City. Utah's PDMP is really good. I've rarely seen a mistake. I check it along with Dr. Minori and Dr. Romankowski, every patient, every visit. So check it. If there's a discrepancy on it, just call their pharmacy. I have a couple patients that had urine drug screens that came up that looked a little abnormal. PDMP wasn't updated yet. Call their pharmacy. They may have had a fill from a dentist or a prior surgery. It's usually just a good time to educate on opioid use and also see if something new is going on in their life. Maybe they had a patient I got called on 2 weeks ago for a PDPMP with a different provider. She happened to have an appendectomy, so we brought her in, made sure she was okay after her bowel surgery. Not a big deal. You know, I'm not going to get on my patients if they have an emergent appendectomy and the surgeon gives them a 3-day script until they can see me. Not a big deal in my office, but I do want to make sure she's okay. When I first started here, though, I had a couple come in. Their urine drug screen looked like it just lit up like a Christmas tree with different substances. I pulled their PDMP. They had 26 different providers in the state of Utah prescribing. Actually, I think you and I did that case, Gary. And so, again, didn't discharge them, but the opioids had to come off. There's clearly an opioid misuse issue going on here and possibly some opioid diversion. So evaluate, 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 and also evaluate when they should come off. Let's see this next slide here real quick. Okay, we'll get a couple generic scenarios where patients come off. Acute post-surgical pain, probably the most common. You know, it used to be they got them for a month. Now it's about 3 to 7 days in most hospitals. Patients who can't come off after 7 days, I would talk about what that weaning plan looks like from the get-go. If you see them preoperatively, start the conversation then. Get that expectation in there that one of the steps of healing from surgery is going to be coming off all pain meds. Maybe they don't need the Valium after the spine surgery a week later, or they come off the oxycodone. That's the goal. Minimize the meds, get them more functional. The second group I see are people that may have mild opioid misuse. I wouldn't expect everyone to do this. Our office, we count our tablets every visit. We've done some quality metrics inside our office with patients who've had opioid or developed opioid misuse. We've found that when they're off by 1 tablet in a 30-day period, their risk for developing opioid misuse in the future is pretty high. And so we would call that like a mild aberrancy. And so that's a conversation to come down, come off, find something else, or go on to buprenorphine. And that can usually be a pretty agreeable conversation. Often it's happening and they don't know. They took an extra tablet because they're having a painful night or they forgot. The other thing we see is patients start to develop dementia. They forget how to calculate and track their opioids. So again, it's a way to monitor for safety. The third group is the one we think of the most, and I had this happen this week. A gentleman who came in, looked very anxious, looked very nervous, have an alcohol breathy smell on him, was supposed to be there for a procedure and asked to talk about his medications. As we talked about his medications, we come to find he was crushing his Oxy 10s every 3 hours and snorting them. That's a situation where we just said, you know what, we're here to take care of you, but let's knock him with oxycodone. And so he went on a Suboxone. That was what, Wednesday? So far doing well, no phone calls. But there are situations where patients need to be taken off immediately, even if withdrawal is going to happen, because the risk of death is a lot greater than the risk of withdrawal. The only people that we know of, too, who've died of withdrawal are prison inmates who go in, and they're dying from the withdrawal because they're not getting appropriate follow-up when they go in. We also see binge rates get really high before someone has to go into a state or federal prison. So a couple generic scenarios to kind of watch out for. Dr. Romankowski mentioned the 5 A's. I would say medical legally and as effective as to be an effective physician as well. If they're on an opioid, track the 5 A's, put it in your notes. It's a great way to ease into the opioid conversation. Instead of just saying how many pills you take in a day, what's your pain like, you say, hey, tell me about your activity. I started you on Norco 10s 3 times a day last visit. We set these couple goals. Tell me what the last month has looked like. How much pain relief are you getting? With analgesia, remember though, in pain medicine, placebo effect is up to 35% in pain. So I like to see 36% or more. I guess you could say 35.1% or more. But I want to see at least that much or more. I don't know that I'm just giving them a placebo because I gave them a medicine, Aberrant behavior, this is highly subjective. Clearly mistaking their meds, stealing meds, getting from another provider are pretty obvious. This can be subtle though. This could be arguing with office staff. They call the MA for an early refill, but they deny it when you're in there. I went into a room about 2 years ago, had a patient very upset. She had a very emotional week with some family things. We asked to counter tablets because our office does that. She knew about this for years before, had done it multiple times, and she threw her Percocet tablets at my medical assistant. I count that as aberrant behavior because most people wouldn't do that in that situation. Adverse events, essentially, are you having any side effects? And again, that's a risk-benefit ratio. Maybe they are, and you continue on it. Maybe they're having respiratory depression, intense pruritus, allergic reaction, severe constipation, and they need to come off. You need to find either a different opioid or a different medication. And then what's their affect? They're coming in lethargic, somnolent. Do they look like they've changed a lot since their baseline? Or do they come in and you're like, oh, Joe doesn't have his walker with him today, or he went, fishing last weekend, and so affect can be good or bad. Now, the SUD, that's substance use disorder. Think opioid misuse, opioid addiction. Loss of control, that just, are they no longer able to take it like they're supposed to? Compulsive use, maybe they're taking it like they're supposed to, but they are watching that clock every minute till that next dose. They're skipping out on things, family time, cutting out short on work. They hoard it. It's something I've seen here. Our state likes to do food storage. We also like to do opioid storage of a lot of patients that want a little extra craving the drug. And this is a question I ask. Even if they're taking it appropriately, I say, when you take the medication, in addition to your pain being relieved, do you feel a big sense of ease, like a cravings being, and you can compare it to their favorite food, favorite drink, things like that. continued use. Think of this more in the surgical setting. Surgery's gone well, range of motion backs, function backs. The surgeon is signed off, but they just don't want to let go of that last 1 or 2 tablets. And so that's an area I see that a lot of. And then it doesn't become a chronic problem. I think we all know what that looks like. Someone that's gotten so psychologically attached to opioids, despite really no organic pathology or prior pathology healed. So let's talk here. And this slide, I think right now is still good, but I will say the pain field is moving away from really trying to avoid long acting, just because they're actually a lot more unpredictable because they're in your system for so long, which is counterintuitive what we were taught when all of these came out. So, but when should you think about moving from short acting to a long acting? You know, inappropriate pain control. There seems to be a handful of hours in between doses where they lose a lot of function or their pain gets so severe they want to go to the emergency room. Another one, my kind of opinion is when the opioids are appropriate, if they have to take more than 3 or 4 a day, that's where I should think about long acting. Or could I put them on a long acting to reduce the frequency of pills per day, frequency of pills per month, or can I lower their MME by getting them better control? And so if you can use it that way, I think you're making the patient safer. You're also putting less pills out in the community too, which is nice. So big hindrance is insurance. Insurance doesn't like to play for long-acting meds. A lot of them are new, but there's also a lot of insurance language that is inhibitive of that, especially with buprenorphine products or our drug deterrent projects. And then problematic drug-to-drug interactions. It's in your system for longer, so it's more likely to interact with other meds you're taking, you know. I'm not going to belabor this. These are things to look at. So drug and dose selection is patient specific. We've all seen patients that respond differently to different medications. Opioids is not specific to them. Check back within 24 hours. So I had a recent gentleman I was taking off. He was on OxyContin 80s for the last, like, I don't know, 7 or 8 years. We got him down to OxyContin. He's on OxyContin 80s 3 times a day. We got him down to OxyContin 20 twice a day, and he wanted to go over to a Butrans patch. He wanted to get off. And so we didn't want him to withdraw, so we went with a 20 microgram Butrans patch. When you calculate the MMEs, he should have gone into withdrawal. But I saw him 24 hours later, and he was somnolent, lethargic, trouble thinking, pulse ox was low 90s. And so we pulled the Butrans patch out of him. Clearly, he metabolizes this differently than most, where maybe OxyContin he wasn't as sensitive to, but now a long-acting buprenorphine product he was. So things can be counterintuitive. I would just say do a close follow-up, 24 to 72 hours. Don't do it with your Friday at 5 o'clock patient. I think you'll get yourself into some trouble. This is a concept that about 10 years ago no one was talking about. About 5 to 7 years ago, pain docs are to watch for this, but now it's coming up in more medical literature. I think about this. This is a patient that looks like they have fibromyalgia, but they're on opioids. It's the easiest way to describe it clinically. Often where I see it is, we go in to do a procedure, and we'll take a 27, a 30 gauge needle, a 25 gauge needle, something that should feel like a scratch on the skin, and the patient's jumping off the table. You know, or you scratch, it looks allodynic without the other symptoms of CRPS. Other things you'll see, the meds don't seem to kick in as quickly. They don't seem to last as long. A lot of muscle aches and pains. There's usually a psychological component to it. And any opioid can do this, but the opioids that I see the most, methadone, fentanyl, oxycodone, especially long-acting oxycodone products. Fentanyl, I don't know, Josh and Mathew, fentanyl's the big offender that I see the most. And so here are some typical doses and studies. I think anecdotally, clinically, it can happen on any dose, and I've seen it happen on any doses. In studies, though, these are the doses they see it more likely to happen on. But if you're on an opioid, it's possible. And some studies estimate that this to be as high as 25 to 30% of patients on opioids experience this. So this is one when I see patients, I talk about opioid tolerance and hyperalgesia right off the bat. I want them monitoring themselves for this. It also gives me a good reasons to rotate them lower or get them off to keep them safe. This happens a lot if you're looking for it. We're going to get this, yeah. 2 concepts we'll talk about a little bit later too is opioid tolerance versus physical dependence. The top 2 bullet points are really the key indicators. You can have both at the same time. I would say everyone that's opioid tolerant is opioid dependent, but just because you're opioid dependent doesn't mean you're tolerant. So opioid physical dependence is the person that function goes up when they take their opioids. This is the guy or girl that says, hey, I needed to do housework. I can't take care of my lawn. I have a hard time going to my job if I don't have it. The opioid tolerance is that same patient coming in later saying, I can't do it anymore despite my normal dose. And they're often taking medications as prescribed. They're good patients. Toxicology screens are good. And so, again, educate early and often on these, because the patients that know about it, they'll come tell you about it. And it's a good option to get them on something a little bit safer, or even just rotating opioids. And then I want to highlight this bottom point. These are not addiction, have nothing to do with addiction. People with opioid addiction can have these things, but if you're on opioids really greater than a week, 5 to 7 days, these 2 can happen at any time after that.
I'm sorry, I have to ask. Physical dependence, that's a little confusing.
Yeah.
I normally think of that in the context of the person doesn't need it, like alcohol.
Yeah.
And then they can't do without it after a while. But a lot of your patients, they're dependent because that's their treatment.
I have a lot of patients that opioids are appropriate for. Their dose doesn't go up, but they notice they will have a functional decline if they don't have, like I have an 81-year-old lady on a Butrans patch. If she has that patch on, she's up, she's doing her laundry, she's cooking herself dinner, she can go out to eat with her daughter. When the times were before she was on that, she couldn't do any of that. And now if we were to take it away, she would notice that functional decline, but she'd also chemically be able to go into withdrawal now, right? Because those receptors aren't saturated. So she may develop tolerance though on that patch though, where she comes in say a year from now and says, I can't do what I was doing a year ago on the same dosage. And that's the thing about tolerance. Or say I start to find out she's selling it to get Oxy. Then I'm worried about addiction, diversion, but yeah, it's...
But dependence can be appropriate.
Can be appropriate, yeah. And I would not only say appropriate, I would say it's almost expected. He asked about physical dependence and kind of, is it appropriate, is it expected? What type of patients you would see that in. So, but yeah, just like, think of hypoglycemia, right? Or in a diabetic with insulin, right? They become dependent on that chemical as well. If they don't get it, it changes physiological chemicals in their body that then produce physical symptoms. So yeah, great question. So opioid rotation, there's several ways to look at this. What it really is the ability to rotate between opioids for improved pain control. You can also use this as a way to soften the blow of taking somebody off. So say I'm a patient with Dr. Romankowski, and I come in and say, Dr. R, I want to be off my Oxy 10s 6 times a day. I don't want to be on it. I don't like them. They make me constipated. But I'm super freaked out about withdrawal. Well, he may say, you know what? Why don't we switch you over to Norco 10s? I'm still getting 6 a day. They're both 10 milligram tablets. But oxycodone, 60 milligrams a day, is equal to 90 milligrams of morphine, whereas Norco is equal to 60. So he has the option there to still give me an opioid for my pain control, let me have the same frequency. He now makes me way safer because now I'm not at 90 milligrams a day, I'm at 60. And he's also softened the blow so that I don't go into full-blown opioid withdrawal. So this can be used for a lot of reasons. Improve pain control, help someone wean. I would say, like the patient I mentioned with the Butrans patch, you gotta watch carefully because different opioids in different patients act differently. And the reason that is because the mu receptors in our body have little subtypes. Like, we all have keys to our home, but my key on my home isn't gonna work on your home. And so those subtypes are like that. Let's get into some nitty gritty. So to do this, there's lots of tables that show you how to equate one opioid to the next. The three easiest are oxycodone, morphine, and hydrocodone. We have pretty good data on that. Where it gets super gray is like methadone, tramadol, buprenorphine, tapentadol. My biggest advice here is whatever table you're going to use the same table. I like the CDC table's pretty good. I like to use one that I think their online interface is good. It's Oregon Pain Guidance Calculator. So whatever you're using, just be consistent in what you're using. The CDC one's pretty good. Medically, legally, that's probably the smartest one to use in your note, you know. But anyway, it's just a way to calculate one opioid into the other. You can do it with IV, sub-Q, or oral. I'm going to focus more on oral, and I won't get into some fake calculations here. Generally speaking, morphine and hydrocodone products, those are 1-to-1. A milligram of Norco equals a milligram of morphine, whether it's long-acting or short-acting. With oxycodone, so 1 milligram of oxycodone equals 1.5 of morphine. Oxycodone is more potent. So that's the example I gave if I go to see Dr. R. I can be on 60 milligrams of oxycodone, but that really is equal to 90 milligrams of morphine. Less oxycodone is a lot stronger than the same dose of morphine. And then hydromorphone here, they give this 7.5 to 30. If you want to do quick math, it's a 1-to-3 ratio. We know hydromorphone is pretty potent medication. It's more potent than morphine, generally speaking. You can use a 1-to-3 there. If you get into sub-Q and IV, I'd get an online calculator, because you're going to have to bring in the frequency of the patient, especially if they're on a PCA inside the hospital. Those get tricky. Maybe have your nurse and you double check each other's math. But yeah, and then parental and PO. If you're really getting into this, you're probably a palliative care physician. And again, they're all using the same calculators, but whatever you do, use the same calculator. Don't switch back and forth. If you have two you like to use the one that errs on the side of a lower dose for that patient. So I talked about this a little bit. So when we switch, so that Dr. R to me scenario, when he changes me from oxycodone 60 milligrams a day to Norco, he's calculating in this thing called cross tolerance. Cross tolerance is the medical word we use to explain these mu receptor subtypes. So like my patient with Butrans, he probably had a mu receptor subtype that was super sensitive to Butrans, but not as sensitive to OxyContin, which is why he was way more lethargic or opioid overdosed on a lot smaller and generally a lot safer medication. And so what we do to combat this is we change from one opioid to another. We're decreasing it by 25 to 50%. So my recommendation when you use these is whatever opioid they're on, convert to oral morphine, and then convert that oral morphine dosage to the new one, and then drop it by 25 to 50%. And that 25 to 50% is really your clinical judgment. If you're really, really worried about withdrawal, go closer to 25. If you're really, really worried about that patient overdosing, maybe they're on a high dose of gabapentin. They're also on Valium for anxiety, and they have poor kidney function. Maybe cut that more down to 50. You're not the only one, man. You're good. It's funny, Cleveland too, man. I don't know what it is. So, but anyway, that's what I really want to highlight on this slide, and then follow up early. The one caveat on this is methadone. We have not come to an agreement on how to calculate methadone. So the one caveat here is you're actually going to cut it down by 75 to 90. If you want something super easy and super simple, if you're taking someone off of any opioid, start methadone at 2.5 milligrams twice a day. And I wouldn't change it any sooner than 5 days. The comparison I use with methadone and buprenorphine is they're more like compounding interest, like right on your credit card. So they're going to build up over time. And so what you get on day 1 for the same dose is going to be different than day 7. Unlike oxycodone and hydrocodone, that's more cash-based. That 10 milligrams is in and out in 4 to 6 hours. So I let patients know this. If they feel like their pain is undertreated day 1, I let them know that may be very different on day 7, even though I'm not going to change the dose. They build up in your body. Think credit card versus cash. So that being said, I don't switch anyone over to methadone. I haven't done it in 5 or 6 years. I used to use it a lot in San Antonio with my practice there, especially with my cancer patients. I had a fair amount of people with HIV neuropathy there. It was really helpful for that. I don't use it anymore because there's more and more data coming out on how difficult it is to predict from a cardiac. So practically speaking, I don't prescribe this unless I'm taking somebody off it anymore. And I'm gone that way with fentanyl too. It's hard to predict. I had a patient in training was on methadone for 30 years, 5 milligrams 3 times a day. We got EKGs twice a year, was doing great. He got his new prescription Friday, same dosage for 3 decades. He was put on, I think it was azithromycin over the weekend for a sinus infection, changed the cardiac rhythm, he was dead on Monday. And so, really, really sad case. Medically, nothing was done wrong, but it just really made me untrust that medication. So guidelines for opioid rotation. Again, they're going to give you this equation here. Take your current opioid, put it into what oral morphine would do, then make it to the new opioid, and then reduce that by 25. So the calculation would be 0.25 or 0.5. And then again, this is based upon your clinical judgment. This next one below, this gets into the concept of breakthrough pain. So I would say kind of 1990s pain medicine we're all familiar with was 2 or 3 doses of a long-acting, and then you'd fill in about 15% of that total dose with a short-acting. That's what got us into the opioid epidemic. Multiple opioids in the system at once, too much. This is still really great advice for people with cancer pain or really severe chronic pain. I would say if you can avoid having a long-acting and a short-acting, stick to 1 category per patient if possible. It keeps them safer. Even if you have to increase the frequency or a dosage of 1. I also, practically speaking, think it confuses patients less. Less meds, less confusion, especially with opioids. And then when you consider adding this, is they're low risk and you're following up regularly. Maybe they're a high risk patient that develops terminal cancer. You know, they're on buprenorphine, but now they have multiple myeloma. That may be a patient you actually decide to go back, and there's a human side to this too. Substance and opioid use patients can still get sick and get very sick. And they're gonna, you know, we all have to cross that bridge of end of life sometime, including them. You may want to add on a short acting on top of the buprenorphine. Maybe add on a long acting. Do shorter prescriptions, have them come in more often. Talk to their oncologist or palliative care physician. So there are reasons to go into this. So abuse deterrent formulations. There's a lot of these out there. That's Xtampza, MS-Contin, OxyContin. Gosh, there's a handful out there. The big issue with these, honestly, is insurances don't cover them. I mean, OxyContin's become a lot harder to get with distribution channels. MS-Contin and Kadine are probably the easiest, but they also cause a lot of side effects. And then ones like Xtampza, hard to get. Nucynta is actually a fairly good one. But again, they're hard to get. But if you can use them, they're not 100% risk-free, but they do make it more difficult to abuse. And so they're right for certain patients. Hopefully they'll become easier to get by when they become generic. But there's really not many besides MS-Contin and OxyContin that become generic yet. So this really should be called toxicology testing. Urine drug testing is the main way we do it. Obviously, oral swabs are becoming more popular and available. And then if you work inside the hospital, serum testing. If I used to be a paramedic, if I was an ER physician, CBC, CMP, toxicology screen, that's what I would do. And I tell our ER docs that just because a lot of behaviors can be explained by either A, prescribed medications that you just don't know about because you don't have access to their file, or B, illicit substances, especially fentanyl, are becoming more popular. When you do this, I would A, use it as a way to keep the patient safe, not as a way to be, we love our law enforcement officers, but that's not us. So don't use it as a way to police. Medically, legally, I would always document the patient agrees to this, and I would make sure it's in your office medication management agreements. So you don't ever get in trouble for having someone do a urine drug screen and they come back later and feel like they were forced to do it. Document the date and time of the last dose and any other chemicals they may had in. Like my gentleman who was crushing his oxycodone, I could smell some alcohol in his breath. When did you have your last drink? Just so I could make sure those things were showing up there, that he was being honest with me, and I could also make sure there were no other meds that would interact with the oxycodone and alcohol. This varies, false positives and false negatives, on what type of test you're using and who's doing the testing. For example, the ones we use at Intermountain, I don't know if you guys have seen this, Belbuca and Butrans never show up positive for me. I get a ton of false negatives in patients that take it. I have to go on a trust issue with there. So just know, have your lab's number close by if you prescribe a lot of controlled substances. And then I always clarify before I confront. And even when I have to confront, it's not the first question I ask. And I learned that, hopefully I'm still a young physician. As a younger physician, maybe a dumber physician, I did that in a patient. I then did his physical exam, and I pulled up his shirt to look at his facet joints, and he had a .40 caliber Smith & Wesson in the back of his pants. About right after I confirmed, I thought, oh, this could have gone really bad. So anyway, I would do an exam and maybe a pat down before you confront. He's fortunately very nice. I still see him today. But that could have gone really, really far south for me. So Dr. Ockey, who's not here, is very tactful about this. We really try to center that conversation on, like, you know, tell me about your pain, and if it's been up, okay, your pain's obviously been more severe. Are there any other medications or chemicals you were taking to treat that pain? That'll de-escalate right there and keep you safe. But be tactful, be smart, but also be medically, legally safe. I'm not going to get into the pros and cons of different lab testing. That's why I became a doctor, not a PhD. But most office-based screening tools, the urine in a cup test, they're immunoassays, and there's a lot of sensitivity and specificity variation depending on which company and distributor you're using. I would say if you're in a healthcare system or you do a fair amount of this, I would team up with a lab that uses more confirmatory testing, because their specificity and sensitivities are really, really high. They're also more accurate and consistent. You could even get percentage rates of false positives and false negatives for your patients when you use them enough, which is nice. Turnaround time, though, unfortunately, with this is slower, usually 2 to 3 days. So there's a give and a take here. But whatever you're using, be consistent, know the false positive, false negative rates, and I would evaluate it annually to make sure the company is giving you good results. So if I'm not going to go over each one of these, what I do is I have this in my cell phone, and I have it slid under a couple of my computer desks. It gives me at least the first column, the name of the medication or chemical. Second, how quickly does it show up after it's taken? And the second column is how long will it last in your system on a one-time use. So obviously, like medical or like cannabis up here, right? This can actually show up 30 days after, but that's usually in people using it fairly frequently over time. A one-time use, it's usually out within 7 days. The one thing this doesn't do is this may vary based upon how they put it in their system. Obviously, you inject it, you snort it, you vape it. That's going to show up a lot quicker than if you take it orally. So the poppy seed, this is the one we love seeing. I promise it wasn't heroin or morphine. I just ate 3 poppy seed bagels before I came to your office. So, and there's some discrepancy in this in the literature. So I looked at this again before this lecture. So poppy seeds notoriously get accused of showing false positive for morphine. We just tell, this argument drives me nuts. We just tell our patients, you can't take other opioids, you can no longer have poppy seed products. So, but about 90% of the opium is removed from poppy seeds in processing. For it to show up in a urine drug screen, it's usually 3 medium-sized poppy seed bagels. That's a lot of bagels. You know, so that being said, there is some discrepancy though on how sensitive some of the newer tests on picking these up. The other thing I would note on this as an example, this is more the morphine oxycodone pathway, is know the metabolites of the meds you're prescribing. So like in this case, we know if we see morphine in the urine toxicology test, there's really 4 options that's going to come from. The 3 poppy seed bagels you had at breakfast. Maybe you got T3 or T4 after a dental procedure, you had a root canal, pretty reasonable. Or you had a fun weekend and you shot up heroin, and so we've had that happen. But those are your, or you have a prescription for morphine. And so keep it plain, keep it simple. Hydrocodones that way. You can have the poppy seed, the codeine, the morphine, and then those can all show up as hydromorphone, as well as just getting hydromorphone. And then oxycodone, oxymorphone are similar. But obviously, if you have morphine in your system and you're prescribing oxycodone, there's a conversation there. The one thing I would say, and I haven't seen this in Utah, actually, I saw it a fair amount actually in San Antonio, is the 6-MAM metabolite. That only comes from heroin. And the false positive rate for that is negligible. It is heroin, and I don't know, until proven otherwise, I don't know how you prove it. So anyway, and the same thing goes with TCAs, benzodiazepines. Know what you're prescribing. If you have a question, call your lab. So when should we stop an opioid? This is a good conversation. This has changed actually the last couple years. I think we all remember the CDC rolled out their guidelines, and their option for when you should stop an opioid was always, 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 and always often. We've learned, though, when you stop opioids abruptly, your suicide rate goes up. And the other thing that goes up is patients wanting to go have illicit fentanyl, illicit heroin, because now they have untreated pain. So couple examples we give here. Their pain decreases after surgery. Now they're stable. Let's get them off the opioid. So they had a total knee or shoulder scope. They have really bad side effects, and maybe that opioid or certain opioids just don't work for them. And then it's just not getting to their functional goal, or they just get tired of taking it. That happens a lot too. The 4th reason they don't have here is aberrancy, which it kind of talks about down here. But like my guy snorting his oxycodone, A, that's medically unsafe to do, and B, it'd be medically legally stupid for me to continue doing that. And probably unethical, I would add to that. So this is an area that gets really tricky. Because if you talk to CDC, it would say get them off like yesterday. But then if you read Health and Human Services, it's going to say no non-consensual weaning. Don't ever take an opioid away unless the patient agrees with you. But that's tricky because some people need to be off of it. They don't have the insight that they should be off of it. And the longer they take it, the increased risk for death, So this is going to be a lot of shared decision-making on the medications. Why are they overtaking it? What's it look like to come off? Timing is huge on this. If it's a patient you trust, who's compliant, you have a good relationship with, that may be a lot longer process. I have a lady, she's been on Norco 10s 8 times a day for about a decade. I met her about 3 years ago. She wanted to come off her Norco. Her husband passed away from COVID. We paused, we stopped. And so she now sees me every month, and we talk about every month. And as she kind of heals from her husband passing away suddenly, we're going to revisit that. I have my oxycodone guy. He came off immediately. And I have a lot of other patients that want to come down, and we go down low and slow as long as there's no safety issues, no urine drug screen aberrancies. But this is an area that the art of medicine comes in tactfully, having good bedside manner, good relationship with your patients. Bring in family if you can. Sometimes family wants them off it more than even you do. So you know your patient's best. It's a decision. Please justify that decision, though, in your note so that the other doctors or reviewers know exactly what you're thinking. Ones you actually, should do right away, they forge prescriptions. I had a partner in San Antonio. We were still doing paper prescriptions then. He liked to put extra zeros on hers, and one day he used a red pen instead of a black pen. And so that was not only a medical issue, it was now a legal issue where the police got involved. They constantly keep losing their prescriptions. Once, kind of that, fool me once, shame on you, fool me twice, shame on me. That absolutely applies here. And then diversion. We see diversion happen a lot when people bring in a pill count and the bottle's partially full of the correct med. Then there's other meds that look like it, but the inscription's wrong. Also, a lot of diversion, Dr. Romankowski talked about this. It could be as simple as, oh, I had a terrible night. I sprained my ankle. I took my husband or wife's Norco. This we actually see in that retirement group a lot. I was at a wedding about 5 years ago, out of state. These were not my patients. And the groom had a really bad headache because he drank too much the night before. So he goes up and mentions to his grandma, and grandma says, oh, let me give you a pain pill. And she dropped her Oxy inside his wine. And the pain doc in me was like dying inside because I'm like, oh, you're diverting, mixing with alcohol. Now you're like, so diversion can be as simple as that. It can be as big as a recent patient we found was selling her Suboxone and Valium prescriptions the last year, and her husband brought it to our attention. She'd take the tablets before she'd come in, day before her appointment, and she'd sell the rest. And this was going on while her family was at work, her kids were at school, her husband brought it to our attention. You know, again, we didn't discharge her, but we're using different medications now. How do we assess, though, for opioid misuse? Like, how do we figure out where these patients are in our practice? Dr. Romankowski went into this. There's a lot of different ways to do it. We use the COM in our practice a lot. The ORT, O-R-T, is helpful. There's also, and if I were a primary care physician or surgeon, I would use the ORT. It's like, what, three or four questions? Super simple to grade. It's quick. It's good for your staff. There's also these other ones here, PMQ, PDUQ, and the SBIRT. These are really nice, but they are somewhat cumbersome for your staff. They are not very efficient, and they're usually used by psychologists, not as us as medical providers. COM's really, really good, 17 questions. I like the questions they use. The other one is a SOAP-R, can be helpful as well. So when to taper, we've already talked about this. The biggest thing I can say is that top one. This is not doc-in-the-box medicine. There's no one way to do this. It's patient by patient. This is where you get into that patient-doctor relationship. Bedside manner is everything, and the art of medicine is always there. You can go up to a 50% reduction. I would say mine are more 10 to 25%. Or like 100%. It's either the lady whose husband just passed away, let's be low and slow and do it together, or it's the person that's like blatantly misusing it. We have a safety issue now. But again, it's individual. Control the pain and withdrawal side effects with other medications. You know, antiemetics, antidiarrheal, increase the NSAIDs, the Tylenol. For specific opioid withdrawal, clonidine has always been the mainstay, but like all of you know, it's nasty when it comes to rebound headaches and rebound hypertension. I always worry about strokes if that hypertension rebounds too much. And I worry about that because eventually those withdrawal symptoms are going to go away. And the patient's going to abruptly stop, you know, clonidine, which can really cause some issues. Gabapentin can be good if they're on it. Just go up by a dose if it's not too high. Lyrica's helpful, muscle relaxants. Make sure they hydrate. Caffeine, believe it or not, can be helpful. So that's kind of me talking, not core REMS, but that works a lot for patients, especially if you can use what they're already on. We do something called buprenorphine inductions in our clinic. So like this gentleman that overtook the oxycodone, he came in 48 hours later. I let him know that next 24 hours is going to be really, really rough, and he came in first thing in the morning. So I could do what they call the chronic opioid withdrawal scale, a COW scale, gauge his withdrawal symptoms. You can do most of that over the phone if you're on call. But gauge the withdrawal symptoms, use what they're already on, treat the side effects of the withdrawal. Clonidine can be used. I personally, it's not my first choice because of that rebound hypertension. And a lot of my patients have hypertension, and so I worry about that. So, and then this is a great recommendation if you have an addiction specialist nearby. I know of no state in the U.S. that has an overabundance of addiction specialists. So I think this is great, but unfortunately a lot of this is going to be done by those of us that aren't addiction specialists. A failed taper is really what that is someone that consensually wants to come off, and you probably went a little too fast. So just pause, give them more time. I would avoid going back up if you can. That opioid variance also increases sudden death or overdose risk. But yeah, I don't think any taper has really failed. Sometimes you're just going a little too fast. Pause, slow down, let them know that you trust them. Do shorter prescriptions if trust is an issue. So when to consult a pain specialist. This looks nice and pretty. I would just say either A, your patients have pain and you don't like to see pain patients, send them over, we love them. Or you get into an area where it just starts to become uncomfortable, you don't know what's going on, you want backup. You don't want to prescribe that opioid. You know it's not going to work in this patient. So send them over to a pain specialist. I have PCPs with me all the time. Hey, could you look at this patient for this procedure in therapy and psychology? But they've been asking for opioids a lot. Could you kind of back me up here? We do it with each other in our office. I'll send Dr. Romankowski a consult. Hey, I think I should do A, B, and C. I really don't want to avoid opioids. I want to avoid opioids in this patient. The risk was high. Let me know what you think, whether it's yay or nay. And so we need to back each other up better in medicine. We're really bad about that as physicians. But use us pain docs. That we're happy to do that. That's very common. If you don't know if a procedure would be good for a patient, I know my specialty is very bad about overutilizing that, but those procedures are also very good. I got a message today on my email. We have a MRI technologist. I need to tell you about this, and I'm going to tell you about it. An MRI technologist. He has a tethered spinal cord since age 4, and he's had it operated on a couple times. He's gotten bigger. He now has a left foot drop, horrible neuropathic pain, and he works as an MRI specialist. And he's been on oxycodone for years. He's in the late 30s, early 40s. He wanted to be off the opioids. And so he finally came in. We ended up doing a dorsal column stimulator, a spinal cord stimulator. It's worked great for him. It took some planning because some of the companies with spinal cord stimulators also don't go well with MRIs. And so we had to find that right company for him. He's taken 1 oxycodone since that implant we did, what, 6 months ago, 7 months ago? So, and his big thing is he wanted to water ski. So if you don't know, just ask. We may say, actually, they've had 100 procedures. Let's not do any more. Maybe they need to see a psychologist, physical therapist, or send them over, let me figure it out. Just early and often is always good. I do say that knowing that Utah is very understaffed when it comes to pain specialists. So I know that's harder in some areas than not. Telehealth has bridged that gap a little bit, so. Document, document, document. I'm not telling you anything your attendings didn't tell you when you were training. And then I'm going to give it back to Dr. Minori. So.
I'll fumble it.
He's not from Cleveland. Pennsylvania.
Close. Very close. Oh, thank you. All right. So I have a brief chapter, but a very important chapter, in my opinion, educating your patients and their caregivers. Dr. Ockey isn't here. I'm going to steal from him again because he's not here, but he's always said it takes 5 minutes to say yes and 30 minutes to say no. So it's a very important thing, I think. With this, our learning objectives for Chapter 6, we want to identify effective communication strategies for educating patients and their caregivers, so family members, friends, about safe use, storage, and disposal of opioids and administering naloxone. And in my opinion, the patient education is a critical aspect of prescribing opioids. It should be done initially and throughout the course of their treatment. So when counseling patients about proper use, these are a lot of the bullet points that you can kind of go through and read. You basically want to be very clear in your instruction about taking them as prescribed and administering to the dose regimen that you've come up together. You also want to explain to patients that they should use the least amount, obviously, of medication necessary to treat the pain, and we want to use it for the short course possible. We want to caution them not to use it for other things than what it's prescribed for. Like, oh, I just took an extra one because I had a headache today. Well, that's, tell me about the headache, that we got to be careful with that and have a communication, or have good communication. And you really want to document what you're teaching to the patient and the caregivers about how to manage these medications at home. Documentation is very important. And to help with that and help with the education, you don't want to just throw a pamphlet at them, but you can use, there's a lot of really good tools out there to help with education too, to take maybe some of the burden off all the education occurring in the office. There's a handout here from the FDA that really goes through and discusses with patients and caregivers about prescribing opioids. In our medication management agreement form, we have 2 little pictures within the verbiage of little handouts, and we kind of give those handouts to them physically. And that's really been helpful in my practice, because a patient will come back in at the following visit having read all that at home and having time to digest it and not feel like they're drinking from a fire hose, and that stimulates further education and further questions from them. So that's a really important strategy, I think. Don't try to do it all in 15, 20 minutes. Use some of these tools that are available. The next slide here, this slide really stresses kind of the importance of anticipatory guidance for patients and their caregivers regarding side effects and adverse events. So respiratory depression is the big one. Opioid-induced constipation, there's tolerance we talked about. John had mentioned the importance of hyperalgesia, but more importantly, opioid-induced hyperalgesia. And this is a really important thing that I focus on with education of my patients. Almost always they have a kind of a light bulb go off, and they actually ask me to write the term down so that they can go home and look it up. There's a lot of information out there regarding opioid-induced hyperalgesia, and I've used it as a tool to try to help to reassess what they're currently on and see if there's better options for them. Other things, cognitive impairments, falls, fracture, poor bone health over a long time. So put in place kind of mitigation strategies to avoid a lot of these side effects is very important ahead of time. Big things that I want to make sure I always warn patients on, right? Don't ever break, chew, crush, or snort the tablets, obviously. If a patient is unable to swallow the pill or capsule, I'd refer to the drug package insert to kind of determine other ways of getting that medication into their system safely. The use of CNS depressants we talked about, especially alcohol, and I had mentioned kind of dose dumping, which can occur. So there can be a significantly increased risk of event with that. So just kind of reiterate the the importance of disclosing all medications and supplements too. They should feel comfortable discussing all medications that they're on and changes that happen to their medications with time. You really want to keep asking about that because it can happen within a couple days. So opioid-induced respiratory depression, obviously this is up again because it's a very important topic, but we're kind of, reiterated this quite a bit. But it is the #1 most life-threatening event. It's most likely to occur, like we said, in 2 populations, so opioid-naive or escalating doses, but also, as John had mentioned, alternating forms of opioids can happen too. And also, with benzodiazepines, other sedation, medications that can create sedation. So really, education is important. And I did mention too, changes that can happen in organ systems like the liver and kidney are very important to be aware of with changing the metabolites in the body. So signs of overdose and poisoning. This is an important slide to also review with your patients and, more importantly, family members as well, because likely they're going to be the ones that are kind of assessing this. This is really important to do. And with prescribing naloxone, it's also important that you also want to, when educating on naloxone, you want to make sure that they're also aware to call 911. You're not just using naloxone and hoping for the best, like this is going to take care of everything. So 911 has to be called, even with the administration of naloxone. You should be doing them both together. And there's not really one correct step. Every situation, I would say, is individual to that situation. So with naloxone itself, naloxone, Narcan, Evzio. It's an opioid antagonist that reverses acute opioid-induced respiratory depression, allowing the victim to kind of regain consciousness and breathe normally. It's important to also know that it will reverse, and talk to the patients about this too. It's going to reverse the analgesic effects, and it can kind of throw them into withdrawal as well. So that's an important point to kind of mention too. There's been a lot of stuff, and this slide says it, what to do. It says consider offering to all patients prescribed. I prescribe it to every single patient I have on an opioid, and I think that's just, in my opinion, the better way to do things. If you're taking an opioid, you're taking naloxone. You know, if you have allergies, you wouldn't walk around without your EpiPen a lot of times, so it's kind of the same kind of thing. It's not the same thing, but I use that as a kind of a way to get people on board with this. Institutions kind of have some auto pop-ups. Our EMR system within iCentra, if you prescribe, it automatically flags, you know, have you prescribed naloxone, and you know, when was it? So it kind of clues me into looking back to make sure, oh, I prescribed it within the last 2 years, because there's shelf life of about 2 years of that. And then it really has no abuse potential itself. So it's available in different forms, auto-injector, intramuscular, the nasal form. There are some videos out there listed on this to kind of walk you through how to administer them, which can be really important for patients, because caregivers or family members can feel a little overwhelmed with this. So these are some good things to have to kind of navigate them towards, so that they feel a little bit better about that medication itself. Safe opioid storage and disposal is really important. You've got to teach your patients and caregivers that safe storage and disposal is essential to protect them, and more importantly, family members. The partnership of Drug-Free Kids developed these 3 steps shown above. But it's very important. I often tell patients, don't carry around all your pills with you, right? I don't force them, but I recommend them at a pharmacy. They can get a spare bottle from the pharmacist that is labeled, so it protects them as well. You know, carrying around those little pill cases, if they're ever, you know, enforcement agency or they get pulled over, they're not as protected as if they had a bottle that was labeled that had the prescriber name on it, and a pharmacy should give that to them. So for me, I tell them that's your 24-hour bottle. If you know we're going to be using 3 pills a day to cover your pain, that's what you fill up. You start after midnight, and that's what you have for the day. The rest stay locked in the lockbox. They only come out of there when they come to my office when we're doing not random pill counts, but we do pill counts every session. And there's reasons for that, but this is kind of it also protects them, but it allows them to not dip into their full bottle. I mean, if they're in pain, it's harder if you're walking around with 60 pills to say, I'm going to take a 4th one today and then I'll make it up tomorrow or the day after. If you open up a bottle and this is your 24-hour bottle and I have 3, then they may make do. They may think about another strategy to go to first before taking that extra pill. Is there another medication? Could I throw some extra strength Tylenol? Do I need to just get out and walk? Do I need to take my mind off of it? So that's been a really helpful strategy. Also, patients who are older who have poor dexterity, make sure they're taking it in a safe place, like on a big table, or there's a strategy too that I tell some patients to take it over a large salad bowl so that if one falls, it's not hitting the floor and going under the rug or under the couch for their dog to get to it, or a grandchild who's crawling around. So, I mean, these things look like candy, so it's really important. I mean, it seems very simple what I'm telling you, but it can really be effective in some patients. So the last one here, where and how to dispose unused opioids. There are safe options for disposal of expired, unwarranted, or unused medication to reduce the chance that others may accidentally take the medication. The Disposal Act of 2014, it kind of allows the following here to administer mail-back programs or maintain collective receptacles. So law enforcement, authorized manufacturers, there are distributors, there are reverse distributors, narcotic treatment programs are in place. Hospitals and clinics can have on-site pharmacies, and retail pharmacies can do this as well. So just be sure that patients are only using authorized collection methods. So review this with them as well. Okay, they're not just kind of throwing them in the trash or flushing them down the toilet and getting in the water system. So, right, and that's it from me. There. What's that? Free naloxone, yes. Yeah, yes. So, yeah. Yeah. This is a really good, yeah, a really good point. So there is ability to get kind of free naloxone programs out there, because a lot of patients will say, oh, it's really expensive, or I can't afford that. So there are options for them to have it now than maybe there weren't years ago there. So, thanks, Matthew, very much for that.
I promise I'd like to talk this much. A lot of these chapters I'm covering for Dr. Ockey, so thanks for being patient here. So we're going to get kind of into the nitty-gritty of opioid use disorder. A lot of it we've already talked about, so I won't rehash things we've already covered. So opioid use disorder really lies in this intersection of patients who are usually appropriately on opioids and have most likely chronic pain. It can happen with acute pain, but we really see it clinically in this group of people that have been on opioids. Literature would say greater than 5 days. Chronic pain is defined as 3 months. And they start to, the craving grows the longer they're on the opioid. Then they start to misuse it in really subtle forms, or sometimes really blatant forms. So the overall specific statistic is anyone on chronic opioid therapy for non-cancer pain, 26%. It's 1 in 4 on non-cancer pain. Now, that statistic does hold true for people with cancer pain. We don't look at it that way because, I mean, ethically, sometimes the need for that opioid for their pain outweighs the opioid use. One caveat here is a lot of my patients that may have opioid use disorder, or they've been on opioids for a long time, then develop cancer, an intrathecal pump with morphine or a couple other medications can be a really nice way to better control their pain and also decrease that tolerance and opioid misuse. So keep that in the back of the mind. We don't see those as much as we used to, but it's a great option for people in this scenario who develop terminal cancer or cancer that's not going to go away quickly, you know. So what is addiction? So and I'll read these because it's very specific definitions that where words have intention. So it's the continued use of any drug, chemical, or activity with the individual who's doing that continued use knowing that it's harming them. So in my case, it's the guys from the oxycodone. This could be alcohol, this could be Valium, this could be a sex addiction, this could be, anything, an addictive behavior, chemically or an activity. So, but it's really a hodgepodge or a mix, though, of interactions among different, brain circuits or pathophysiology. We know about genetic predisposition. Alcohol was kind of the groundbreaking work on that in families. Environments, physically, emotionally, what they're in, and an individual's life experience. So the DSM-5, we're all familiar. If you look at this, this is their very specific definition. They have to, so this is where we'll get into this. So the DSM-5 says the opioid is being taken as prescribed. They can't be addicted. I would push back and say, well, what if that frequency is high enough that your prescribed frequency matches the craving, right? So like my guy snorting the oxycodone, he was written for it every 3 hours. He didn't overtake it. So according to DSM-5, he doesn't have it because he wasn't, but my argument would be like, well, yeah, he's taking it orally, but he's crushing it, snorting it or licking it. And so they look at it as you're not taking it as prescribed, plus you have one of the 4 C's and you have a negative, I'll call it a social consequence. Stop showing up at work. You have a bad relationship with your spouse or your kids. You internalize. We saw this with COVID a lot. When COVID, we went to these home protocols. A lot of our opioid patients loved being on telehealth. Then as we came out of COVID, it was hard to pull them back out to do physical exams because they really got very introverted. Are they doing something physically hazardous and physical or psychological harm to them or someone around them? This is where that DSM-5 is. They can have opioid substance abuse with a real legitimate chronic pain. I have a gentleman that had multiple myeloma, chemotherapy-induced peripheral neuropathy, and as he came out of that and his cancer went into remission, he kept, and we were weaning down, he kept overtaking, and so he had developed opioid misuse probably through his cancer diagnosis, and so we're working on that. So you can have opioid addiction even if they're taking it as prescribed. It's just you probably have the dose high enough or the frequency high enough where you're meeting that craving. So we've talked about this a lot. What I would say here is people with opioid addiction have dependence intolerance. And if you have aberrant and problematic behavior around an opioid or a substance, you have all three. But just because you have dependence and tolerance doesn't mean you're addicted. And you can be addicted without showing aberrant behavior. It's just a lot harder to determine that in a patient. So the big three areas in our brain that form this addiction center are first the periaqueductal gray, two the nucleus accumbens just anterior to that, and then inferior to both of those is the locus coeruleus. And so I remember this is, I keep it super simple for me. Periaqueductal gray has a P, that's your processor. The nucleus accumbens, that's your reward center. That's the nice job and need it more center. That's that craving, like you feel great when you take it, attaboy, and you don't have it, you want it more. And then the locus coeruleus, that's where that dependence and withdrawal center comes. I mean, you need it when you don't have it. And so it creates this vicious cycle we're all familiar with. We start with this binge. We get this dopamine and opioid peptide endogenous binge that just makes you crave it and makes you love it when you get it. And then it wears off. You get this withdrawal and these negative side effects of withdrawal symptoms, social side effects. Maybe you feel better when you're on it psychologically as well. And then you get in this area of preoccupation, anticipation. This is that like kid in the marshmallow experiment, you know? You put a marshmallow in front of a kid, how long can they wait to grab it? Instead, now we have adults with opioids. And so this is this. And so there are different neurotransmitters that they all have a play, but they all kind of take center stage. So with the binge, it's dopamine and opioid peptides. We get into that withdrawal and negative effect. That's more the CRF or corticotropin releasing factor and dynorphin, and then glutamate right here. Where it's different with people that do not have addiction is they often want to stop here if they feel like they've, you know, you've heard patients where they take an open, like, oh, that made me feel weird. Or I felt really good and it scared me. These are people that experience the binge intoxication scenario, but they have enough insight or their environment, they have different set of genetics, where they recognize this. They don't want to be in this cycle. They stop right here or right here, and they don't ever get this preoccupation, or it never grows enough where they crave it and it keeps going. And so there's a lot of interplay that makes this circular instead of linear, and that's where environment, genetics, prior experiences, how long you've been on it, really gets to muddy the picture. So low hedonic tone just means you're less likely to feel the wonderful things in life. You don't get to enjoy life as much as the rest of us. A lot of scenarios do that. Those with psychiatric comorbidities. The big three with opioids are depression, MDD, anxiety, GAD, and PTSD, especially PTSD from sexual assault and military trauma. I have a really soft spot after years of being at a VA and military hospitals. I was lucky to train in a clinic with, the clinic was cool, I'll share this. So I had 4 physicians there. One was the military police in the first Gulf War. The other one was a Navy SEAL throughout Vietnam. The third one, she was a 20-year Air Force veteran. The fourth guy was a Delta Force former Delta Force under Donald Rumsfeld for 10 years. And it was interesting, on Fridays, we'd be in that clinic getting everything ready for the next week. You know, you're the intern and they're clicking away doing all their notes. They would start talking about their experiences and often talk about a lot of their veteran friends that weren't with us, had committed suicide, ones that had gotten to the clinic. There's a really robust military connection in San Antonio for these vets. But it's really that PTSD one is one we forget about because we don't see it a lot in our civilian clinics. But I would say when we ask, it's pretty prevalent. I probably see once a week suppressed sexual trauma or physical abuse from childhood. When this comes out, a lot of our vets that were World War II, which unfortunately they're not around as much anymore, Vietnam, Korean War, we weren't screening for opioid use and PTSD in those wars. We weren't. That was more like an OEF, OIF thing. And so I would ask about it. There's a lot of it that goes unspoken and it comes out as we start screening for this. This can happen after 5 days of opioid use. Most people that go on to abuse heroin was not the gateway drug. It was a prescription opioid that was longer than 7 days. So keep that in mind. So once we diagnose the opioid use disorder, how do we take care of it? If you have an addiction center, my recommendation would be refer them on to there. Let the specialist treat it. These people can need a lot of support early on and a lot of monitoring later on. If you're someone that enjoys addiction medicine, the methadone was very much the mainstay treatment for decades. That is more and more becoming what we use for people with heroin disorder and methadone maintenance clinic. Again, another area we're understaffed here in Utah. Buprenorphine about 20 years ago kind of came on the market, and that is now, I would say, mainstay in chemical treatment with it, especially with Suboxone is the big one, right? Buprenorphine and naloxone. Sublocade's a newer one where it's an injectable form once a month. I think you'll see that be a lot better option once it becomes generic, just because you're not feeding that psychological habit by taking a pill in your mouth. A lot of patients on that do well. Naltrexone, not a controlled substance, gaining more popularity. I think you've done this a couple times, haven't you, Josh? In the pain group, I have to educate myself better, something I'm looking at, but that can be really good for that mild opioid misuse, where maybe they're overtaking 1 or 2 tablets a month, they're a day or two short every month. That can be a great option to control pain and craving. And then with this biopsychosocial model, check out their environment. Are they in an abusive home where someone's hurting them? Did they previously come from one? Has something changed? They're divorced, they lost a spouse, they had a child pass away. Just last night, I had one of our nurse practitioners call a patient whose husband's not making child support in a recent divorce. She's overtaking 2 or 3 tablets each week. And so we shortened the prescription. Her mom's going to take care of the medications now. And she's already on buprenorphine. And then where do you go with this? Do you trust them? Is it really, really severe opioid misuse or heroin misuse, and they need daily check-ins at a methadone maintenance clinic? Or is this someone, they're on a stable dose, you see them every 60 days, they're on Suboxone, and they've been safe for years? Opioid misuse can change a lot, especially if it came on from an environmental or a family situation. It can change over time and reevaluate over time. And then the big issue we're seeing now is this last one. I would say patients who discontinue or patients who are never offered the medication addiction treatment, they'll go to the street. A lot will go to the street and get what they need there. This is a big area I have an issue with my own specialty. As much as we love the interventions and they help and they're fun to do, we've somewhat, as a pain specialty, have forgotten about this holistic side where we need to own the opioids, own the opioid epidemic, so that patients don't go to the street to get medications. Like Dr. Romankowski said, it's unregulated, not only legally, it's unregulated medically. We don't know what's in what they're taking, and we don't know if it's going to vary from dose to dose. And we're seeing this. Fentanyl rates are through the roof. It's like 700% in some communities right now. I mean, it's just gotten out of control. There's a couple things to remember. Untreated pain. So when you diagnose the opioid use, you're going to have to monitor the pain and the craving. And that may guide your buprenorphine dosage. It may guide what other adjuvant meds you give them. but also don't be a prisoner to this, because they're going to come in and tell you their pain's untreated. And that's why tracking goals may be a better method than just tracking pain. And then be careful of the medications they're on. This says consider a multidisciplinary pain program. I would say if you have them close by, do this way before they get here. Let these pain programs help take patients off of them so you're not alone and they're not alone. And then again, on this side, if you have a program around, let them work it. And then remember you're using your MMAs, pill count if you need to, check the monitoring system, and toxicology screening. So a couple at-risk groups here. So we all know benzodiazepines and opioids don't mix well. They like each other, but they don't play well. 30% of people who have opioid overdoses, whether they die or not, were on one of those two. And it may have just been, maybe they got a Valium for an MRI, or they had a colonoscopy the day before. I always educate. If they're getting a benzo, we're going to decrease that opioid for a day or two if they're going in for an elective procedure. The group we forget about a lot, and we don't see this as much here in Utah as we do in other states, nicotine and alcohol abuse are as much of a risk factor as benzodiazepines. You got someone that's smoking, there's clearly an addictive behavior there. So we give them now an opioid, an equally potent chemical. We got to monitor it the same. And it may be a great way to get them off that. Maybe they do justify an opioid. So maybe use it to get them to stop smoking. And then the big ones here, any of these chemicals, this number goes up when you have those two chemicals and a psychiatric condition like we already talked about. So buprenorphine, let me give you a couple things that I think we get a lot of questions on. There's the buprenorphine waiver, and it's about as clear as mud on who should have this and when do you get it. So you need this only when you're using buprenorphine to treat an opioid misuse disorder. If you're using it to treat pain, your regular DEA license is sufficient in any state. The other thing I would say here, and these medications aren't on here, when it's used for opioid OUD or misuse disorder, think Suboxone, Zubsolv, Sublocade. Those kind of three kind of put them automatically in an opioid use disorder. For pain, that's where Butrans and Belbuca have come to the market, and they're dosed differently. They're dosed in micrograms or micrograms per hour. And then Subutex, too, is the one that kind of goes both ways. So just to clarify that. Now, these are a partial mu agonist, so they can still cause respiratory depression. They can still cause all the nasty opioid side effects we don't want. It's just a lot less likely because of this plateau or ceiling effect. Most people for chronic pain don't need buprenorphine higher than 8 to 12 milligrams per day. Often it's way lower than that, especially if they're on Belbuca or Butrans. People with substance abuse or opioid use disorder, it can be anywhere between 8 and 16. Some studies show 8 and 20. We used to go up to 24, but we're finding that really above 20, we're really urinating out a lot of that medication. Two good resources are ASAM and this SAMHSA one here. If you need additional information, want to know what's new, or want to know what clinics are available next to you. Okay, this is one, and I'm going to read a couple disclaimers. I have a personal disclaimer. So I have no, I don't get paid by anyone or any medical cannabis company. Under federal law, medical cannabis, recreational cannabis is still a Schedule I drug. It's still considered illicit, even though some states, including ours, have either passed law to make it recreationally or medically appropriate in some forms. And then this presentation is just to provide education. We're not going to say we're pro or con for it. I personally, right now, do not prescribe it in my office because I as a provider, want more information on dosing. And although I really, really enjoy the help of my pharmacy friends, I want to know what my patients are getting because I'm the one who's going to be following up on it medically. That being said, I have colleagues that prescribe it, and it really is meaningful for their patients. So, and then I think Intermountain, yeah, that was the Intermountain one. I work for Intermountain, and whatever I say is not their fault, it's on me. So if questions, ask me, don't email Intermountain. So currently right now, the state of Utah, we used to do medical cannabis letters. That's now transitioned to medical cannabis cards. When they get that card, they can go to a state-approved pharmacy and discuss with the pharmacist what products are available and best for their clinical symptoms. Utah recommends those products are not smoked or inhaled, so gummies, tinctures, creams, rubs, things like that. So it's still considered a legal substance, and I know that politically that can be debatable. Most illegally used substance worldwide. UF lifetime, 42 to 46% of us will use this medically or recreationally in our life, statistically. 18 to 25, some would say 18 to 30 is the rate, as the group of people that's most likely to use it, be used, and most interested in it. I do see, though, a growing number of my patients who want to be off opioids, or as they get into 70 plus years, the arthritis, the surgeries, or cancer catches up, it's become an option they want to discuss. And then with cannabis use disorder, that 20-year-old range, 20 to 30, 20 to 25, is the group we see the highest with side effects. And then this just is showing that 0.1 with all illicit drugs right here in green, marijuana being the blue, and below that we get into prescription drugs used inappropriately or illicitly, and then cocaine's the purple, and then hallucinogens like PCP and LSD are down there. So when we talk about cannabis, we're really talking about two different flavors of it. So, and then on the sativa and indica plant, these little hair-like structures, we call them trichomes. It's essentially the cannabis version of cilia, like we have in our body. There's little finger-like, hair-like projections that contain the THC, and that's where a lot of it is taken from. The sativa plant is here. That's got a higher concentration of THC per plant. It's more psychotropic, psychogenic. The indica plant has a little bit less THC, more CBD, and so less sedating, less psychotropic. There are lots of different varieties of each of these. This is very much a generalization. There's different strains of each of these. It varies based upon which part of the world you're in, but generally speaking, they derive from one of these two. So chemically, I think there's 113 now. I looked at this last night, recognized cannabinoids. Delta 9 THC is the big one we hear about. And recently there's been two that they think are actually more potent than THC. It's THCP and CBDP that are being looked at as more potent than just the THC school. And then the other thing that's important is the THC CBD concentration in relation to one another has a big effect on what you get out of the medication or recreationally. And the big issue we have federally is inaccurate labeling. There's really no one that regulates this, or the science is good enough to actually give us good info like we do with our other medications that we prescribe. And then obviously insufficient studies, but that could be honestly said about almost anything we take care of. More studies are always better. So some kind of definitions you'll hear about. Marijuana is the big one. It's a dried plant, including all of the plant, usually smoked or vaped, but gummies, tinctures, oils, creams are now all available. Hashish is actually a concentrated cake that's made from resin or oil from the plant. Tinctures we see, this is a liquid extract you can do sublingually, usually like a little eyedropper is what you'll see patients either with CBD or THC. That's become a popular a way to take it medically or recreationally. Hashish oil is just oil obtained from this resin cake. And then there are ways to infuse it with different cooking oils, butters, other things. That's probably the way we see it the least utilized. And a lot of these that are marked with this number down here, like the infusion, the tincture, and then parts of the dry plant are the medically approved, I'll say, forms you see in most states, from mints to tinctures to oils to creams. So there's two big studies. If you want to look into this, I would look at this one from Kayani in Annals of Internal Med in 2018 is a really good review. This was a kind of a highly, this got a lot of attention when it came out, put it that way. So in the review, 81% of patients believed that marijuana could be medically effective or useful. 66% thought that pain was the most useful thing you could use it for. After they looked at these cohort studies of about 1,500 patients, although medically we saw that it could be used for several different things, there was no evidence that it actually made the patient outcomes for, whether it's pain, seizures, sleep, that it actually functionally made them better or improved outcomes. And it depends on the study that you look at. There's a lot of debate there, good and bad. So when cannabis gets in our system, we have an endogenous system already, and the external cannabis we put in plays off that system. So CBD or THC, CBD in our body actually starts in the postsynaptic terminal, signals the presynaptic terminal to release neurotransmitters across it. The main neurotransmitter is dopamine, but we get bits of serotonin and then TRPV and TRPA along with several others. But dopamine is the big one here. And then where we find these transmitters, there's really two main subtypes, CB1 and CB2. They're both in brain and spinal cord, but then CB2 they actually think is also in the dorsal root ganglion that stick right around our nerve roots as they exit the neuroframen out of our spinal column. The other big difference is CB1 receptors help, it says mitigate sensation, it helps desensitize a painful stimulus. And then CB2 can help with an inflammatory response. That's what you see a lot of our pro athletes, why they're promoting CBD or THC use, is it decreases inflammation after they play. This has become really popular in the NFL as an alternative to opioids. And so I think we'll see more and more with this coming out sooner. No great long-term studies, and then no great studies on how it interacts with alcohol, nicotine, opioids, and other CNS chemicals. So American Psychiatric Association still kind of relatively quiet on this. There's no psychiatric FDA approvals yet, but there are 3 FDA versions of this. So we have Marinol or Dronabinol, Dabibolone, and Cannabidiol. These are generally used cancer patients, AIDS patients with nausea, anorexia, or ongoing chronic abdominal pain. In those patients, like my cancer patients that come in, or my HIV, AIDS, neuropathy patients, if I'm going to look at medical cannabis, I'll start one of these first. If they're ineffective, I have a couple pain physicians that really enjoy having a medical cannabis clinic. I'll refer over to them. So keep that in mind as we talk about medical cannabis. There are 3 FDA-approved products. Dronabinol has been around for decades. FDA approved. It's used in federal VA, federal institutions, and so it can be really, really effective. The other second study I'll give you, actually there's 3 of them here. This is Animal Interest in 2017. This looked at 32 initial studies, but they really honed in on these 27 that were actual trials. What they saw is low-level evidence for chronic neuropathic pain of any sort, just neuropathic pain. And I think clinically I've seen that as well. No other evidence for like nociceptive pain, chronic osteoarthritis pain, the lumbar fusion patient. They did see an increased short-term and cognitive impairment, especially in younger patients. That's what's a little bit different about this, is we see more psychological impairment and psychological issues like paranoia in that 20-year-old range. Most meds we kind of worry about as people get older. This is the opposite, and I've seen this. I've had a couple patients that were using recreational marijuana, and as they came in, we could see their psychological scores in our clinic go down, and neither were on opioids, and one looked very paranoid in office, and sure enough, he was going down to Vegas once a month for work and grabbing some mints down there, but really set off a 6-month kind of depressive paranoia. So something to monitor or discuss. The other good study is this Whiting one in JAMA 2015. That's probably the best and most honest paper in my opinion. It really gives a really broad look of it. That's what I go back to all the time. So there's a meta-analysis and a systemic review. It looked at 8 studies that showed pain reduction versus placebo. Of those, they saw in those 8 studies about a 37% reduction in pain versus 31 in the control group, which is good. But I remind you, placebo and pain is 35%. So interesting, but not as strong as you would have liked to have seen it. And then adverse events, again, dizziness, dry mouth, kind of things we know about. Hallucinations, confusion, I'll add paranoia to this, are ones I see fairly often in patients, especially younger patients. Limitations that Whiting notes is there was no homogeneous methodology. All the papers were designed very differently. They all use different products. That's not the study fault. There is no apples to apples comparison for recreational or medical cannabis. It just, because we don't regulate it from the federal down, it's really hard to see if we're comparing equal products. And then no one's really looked at this specifically in older populations, either by demographic, by decade choice, or by like cancer pain versus non-cancer pain. So this is where this got really kind of heated in 2017, as the National Academy of Science came out and said there was substantial evidence based upon those 3 studies we went through. I'd probably say there's more mild to moderate evidence, so interesting, but we should probably do more. But this gained a lot of weight to use it, especially in areas like sleep apnea, seizures, chronic pain, and MS. But again, it had the same limitations as this one down here. So let's talk about patients you may have on it. How do you lower the risk of side effects? So obviously, if you don't want side effects from a medication, don't take it. It's not rocket science. The earlier the age, the worse it is for cannabis, recreationally or medically. Avoid high frequency, any medications that way. The big one is right here. That THC to CBD ratio can really make a difference, better or worse, with patients. We've not figured out which conditions in which a higher THC or a higher CBD or only THC or only CBD is important. Illegal synthetics are more and more being laced with fentanyl. And then obviously this one right here, an up and coming trend in the last 5 years has been vaping non-nicotine products. Medical cannabis is now falling into that. I would avoid that like the plague. I think we all know that inhaling chemicals, unless it's like an albuterol nebulizer, is probably going to create some issues with long-term lung function and even some short-term lung function we've been reading about now with vaping. So I would avoid vaping in general, but especially cannabis. Even if someone's terminally ill, there's other ways to get medical cannabis without increasing your risk for a pulmonary issue. And then populations where they've had psychosis, schizophrenia, schizoaffective disorder, paranoia, be very, very careful, because you can set them back into those same mental health conditions that they've worked so hard to come out of. And then clinical considerations, obviously risk stratification, both medically, psychologically, and environmentally, and then educate. The providers that do medical cannabis in the state, they're treating it just like opioids. Medication management agreement, toxicology screening, and setting appropriate expectations. If you're going to start this in your clinic, I would recommend making sure you're legally protecting yourself in your clinic. Setting up not only a medically appropriate, medically ethical, but also an equitable way where patients can gain access to it. And then if you want to take a list of this, here are probably some of the better areas to go with questions on it. And then those are those papers I mentioned right there, with that Whiting one being probably one of my favorite ones to read for an overall view of it. Okay, and someone asked earlier, I don't know if they're still here, about Utah-specific laws. And this is actually updated, 2022. That's not correct. So Utah has changed a couple of their laws recently regarding how we write and document and prescribe opioids and how we communicate with each other. So we don't have a lot of data up until 2018. What we do see is 2 things. Our prescribing rates for high-dose opioids are pretty high than other nationally than other states. One, we prescribe a lot more above. The other thing is we also do a better job honestly reporting our data. So that's a pro and a con there. The good thing is we're seeing this come down year after year. The 2020 data was in the 40%. We're doing a good job here in Utah. We really are. And we see that in our clinics too. And then opioid overdose deaths, we're seeing this come down every year too. There was a little spike in 2020 from COVID, but we've seen that come back down again in 2021. We don't have any 2022 data yet for the first or second quarter. And this data here, look at CDC drug overdose. That's a great site if you want to look at state-by-state data or national data. It's usually about 2 to 3 years old, though. We're all very familiar with the PDMP. We have to be able to access it. We have to go through DOPL. Obviously, DOPL's who gives us our license. If you're going to really write any medication, especially anything 2 through 5, I hope you're not writing Schedule 1s, you have to access the DOPL. You can give your staff authorization to access it for you. And then on the pharmacy side, they're supposed to record prescriptions daily, and Utah does a pretty good job of that. We do share data with other states. I think we're pretty good with most of the states around, with the exception of Wyoming. Wyoming, it's kind of hit and miss, and I know DOPL's working that out. And that's becoming more and more common. And some providers have worried that the patients get notified when you access it. They don't. You can access as a way to check on your patients, but they're not going to be notified when you go into it. And if you're a provider or have providers in your office who get prescription meds that are on DOPL, you should obviously not be accessing your own DOPL record. So.
What is DOPL? I'm sorry.
So DOPL is our Division of Occupational Professional Licensing. They're over this DOPL, utah.gov, where they're at there, but they help run the PDMP in our state. So the Prescription Drug Monitoring Program. So in our state, physicians, PAs, and nurse practitioners, we all can prescribe Schedule 2 through 5, and we all have the same requirement of 3.5 hours every 2 years. That's why we're all here today. And it varies by state to state, but for us, it's equal amongst all of us different providers. So a couple things that have changed on this. 2017, they now recommend that we prescribe naloxone with opioids, and they've also mandated that this can be without a prescription, to a third party, and yes, you can call it and make a standing order, and it needs to be carried by first responders. And to echo what Dr. Minori said, if a patient's going to use it, I call it the give and go situation. If you're going to give it, your next step is to get them to the hospital. We had a situation with an intrathecal pump in Park City a couple years ago where we changed out the pump, put the medications in, everything was great. The pump was, there was a faulty pump. And so the reservoir was kind of leaky, and so a little bit leaked out in this gentleman. His wife noticed he was falling asleep. This is an 80-year-old gentleman that doesn't usually fall asleep. She pulled the car over. She gave him naloxone. She came right back to the ER. We took all the medication on the pump. It was perfect. So if they're going to give this, or you're going to give it in your offices, get them right to the hospital. It's about a 30 to 60-minute window, and I would say usually more 20 to 30 minutes. And patients feel pretty bad when they get this. And so they may wake up really alert and even agitated sometimes. But again, you saved their life, so it's worth it. So with new control, I'm going to the next slide. This one's hard to read. So the big Utah law requirement, let me make sure you get this one here. Check the prescription database, the PDMP, for any Schedule 2 or Schedule 3 opioid. They say frequently. In the meat of the law, it says every 3 months. Check it frequently. If you think you should check it, just check it. Just because you'd be surprised when things come up. For every initial prescription, you need to check the PDMP, and this includes any prescription over 7 days. They used to exclude surgeries. They no longer, if there's any surgeons here, if you write if it's over 6, 7 days, check it. Whether that's your nurse, PA, nurse practitioner. And
Are they reimbursing us for that?
No, I wish they would, yeah, because if I got $1 every time we had to check it, yeah, I'd be fishing right now. Yeah, exactly. So, and it adds more task and administrative onto your already clinical day. It does. We went through this with all of our surgeons at Intermountain Healthcare to set up an operational way where a discharged nurse could check it. And if there was an aberrancy, they'd notify the surgeon or whoever was on call for the surgeon. Yes, and it is cumbersome. I agree. When you do this risk assessment, and a risk assessment can be something as easy as you or one of your nurses giving a COM or an ORT, or it could be ER doc who wants a psychiatric screening in the ER, or like me sending one of our psychologists. But they need to evaluate the risk of addiction and overdose. What other meds or chemicals are they on or maybe using? Which again, we don't have a magic 8 ball, so that can be tricky. Why are you giving the prescription? Document that you used alternative treatments and you discussed risk and benefits. I made mine look like a surgical or a procedural consult. And my recommendation would be, if you have an automated EMR system where you can make this the same in every note, make it easy for yourself so that the note works for you. Just make sure if you're putting in your note, you're actually doing it. A couple exceptions to this. Active treatment for malignancy, palliative care, and I believe this includes oncology as well. And then if they're on a substance abuse or opioid dependence, where to me, as much as this was kind of counterintuitive, because this is the group most likely to misuse, and this is the group while we're doing this, right? So we do this to identify them, and they get into this substance abuse or opiate dependence group, and then we forget about it. So legally, you don't have to do it in this group. I think that makes no sense. That's the first group I would do it in, you know? So as of May 2020, 7-day prescription, a Schedule II or Schedule III opioid. This did exclude benzodiazepines, soma, stimulants. Unfortunately, it's just on opioids. And then if you write a high-risk prescription, which is defined as an opioid going longer than 30 days, and you find another practitioner who's writing a prescription. So I write one for Norco, Dr. Romankowski is the psychiatrist and writes one for Valium. I find it in the PDMP is my obligation to call him a letter, a message, a text message, and it says in a timely manner, but they don't define a timely manner. So that's where that changed a lot, and then you have to document it just like we talked. You have to document this risk assessment right here. So, ask away, yeah. I'm not a lawyer, so don't trust me, so go ahead. You could call, a letter is sufficient, sending your notes is sufficient, as long as there's some form of communication. You also, even though you'll want to make sure they receive it, like say I call Dr. Romankowski, I call him 3 times, send him a letter, he gets my letter, make sure the patient's okay. He should call me back, but he's not on the hook if he doesn't. So you just have to make an attempt to have that communication there. What's tricky is we don't know how this is going to unfold legally. There will never be cases in the future that'll probably define this more for us. So it's very open-ended. But yes, a phone call, a text message, an email, a note. I send a provider letter. And if it's something I'm really worried about, I'll have my office call and give that doctor my cell phone. Okay, we're all done. You passed, you survived. Do you want to take a 5-minute break, or you want to go through 14 questions and get out of here? Okay, let's do it. Okay. So, 14 questions here. Question 1, which comorbid condition may predict the development of chronic pain following acute pain? So which of these is most scary, where you're worried about chronic pain developing after acute pain? Yeah, depression, mental health, depression, anxiety, PTSD. And really look for, especially in our veterans, and sexual trauma. Okay, pain secondary to post-herpetic neuralgia is what type of pain? Neuropathic. Yeah, neuropathic, exactly, yeah. Which of the following is an anticipated outcome of a patient taking a prescribed opioid medication? Actually, to get credit, can you guys hand out those tests right there? You have to have proof that you were here and did this, so fill it out while we do it. Yeah. I don't want to get you in trouble. Oh. What's that? Oh, you're okay. Yeah.
Give me a second.
Absolutely. Yeah. If you need to grab a pen, a drink, a bathroom, please feel free to take a quick break.
How are we supposed to identify this?
Put your name on it, and I do cell phone or email, yeah. If I mess something up, let me know, because I think some of these, there's some debate in here. And if you guys want to do the opioid calculation one, make sure I'm right too. I think it's the one, it's Oxy 80, I think, so. We'll give a couple minutes for people to get pens here. And then I believe, did we hand these in last year, I think? Yeah, I thought you guys handed them in last year. And if your name's not on that sheet out there, make sure it's out there before you go, because that's where they recorded that you were here, so.
Do you need just the name?
I do your name, email, and phone number. And then if you give it to me, any credit cards or bank accounts are always appreciated. So, yeah. No, I think they did name, email, and phone number, and that can be professional or personal. So number 1, depression, we talked about. Number 2 was neuropathic. Number 3, which of the following is an anticipated outcome of a patient taking a prescribed opioid medication as recommended? So it's a good patient, yep. Tolerance. So diversion would be someone selling it or receiving it. That's not their prescription. Misuse is usually they're taking their own medication inappropriately. Then obviously withdrawal would be them being off that medication, whether illegally or appropriately. So 1, is B, 2, B, and then 3 is, we're going to mix it up here, and it is tolerance C. What is the first step in an assessment of a patient in pain who complains of burning and tingling in his lower extremities? Yeah. Any disagreement with A? Now, these are all very good, like you should do B, C, and D, but A is obviously, it's your, med school first year question. Always get a history and physical, and EMG would be appropriate. Social history and cultural background are appropriate. And if you have a concern, check the PDMP. So 4 is A. 5, which of the following is the most important thing to consider in creating a pain treatment plan? Yeah, I still track pain, but I'm in Dr. Minori's camp. I want to know function. If I'm giving you a medication, what's getting better? No different than diabetes or blood pressure, right? And I would say the other ones are still appropriate. I mean, besides A, Well, actually, I would only say D and B. The goal is to really resolve pain. I think you're setting yourself up for failure if you're promising that. So 6, according to expert guidelines, which of the following is the best sequence for establishing a pain treatment plan of care? Yeah. You're saying A, Dr. Minori? I want to give Dr. Minori credit. This time yesterday, he was texting me pictures of him fly fishing in Island Park, and he came back early. So he says A, we'll give him A. So, yep, A is correct, yeah. And I don't think any of the other ones would be wrong if appropriate. I mean, B, if appropriate, maybe they have a prostate cancer and bone mets to their spine. C is not terrible. And then D, you obviously want to validate what they're going through. Obtaining imaging is always a good idea. It's the opioids there that, you want to only initiate if possible or if needed, excuse me. Which side effect of opioid therapy should always prompt proactive treatment? Yeah, constipation. This one would have been a better test question if it was respiratory depression. But dizziness, if you had them come in and you put on a fentanyl patch or a Butrans patch, and now they're getting itching and hives, maybe it's just the adhesive. Maybe it's delayed onset anaphylactic, 6 hours after. Nausea too. Maybe they're nauseated from a bowel obstruction from the opioid. But yeah, A is probably the best test answer. I would say all of them are appropriate to assess.
Getting back to the 6 is important too. Really establishing diagnosis is really important. So many patients come in on chronic opioids who never really had a diagnosis established or worked up. So I really think that's important. I kind of harp on that. I tell a patient, he came in my office and I didn't check anybody.
Yeah, absolutely agree, Josh. No, 100%. Okay, 8. In which of the following circumstances is the patient at greatest risk of life-threatening respiratory depression from opioid treatment? Yeah, D is probably the best answer. I would say C and B, though, are right up there with it because you're changing something. During a dosage taper, if I was tapering someone and saw respiratory depression, I'd be worried there's probably some opioid variance there. They're coming down 2 tablets a day. They got nervous. One day they went up by 4 and came back down. That can really be kind of a big issue. So, but yeah, D is obviously the bigger answer. Select the correct statement regarding counseling a woman currently on chronic opioid therapy who is contemplating a possible pregnancy. This was Dr. Minori's slide. And Josh, let me know what you would answer for this one. Yeah, B is what I had. This is kind of a tricky question. It can cause congenital abnormalities. Long-term opioid use does have some risk factors for osteoporosis. But, and then B, although that's the right answer, buprenorphine is becoming way more commonly utilized than methadone. And then neonatal abstinence syndrome is, I would say, not rare if you're on an opioid. I would say to anticipate it or expect it if you're on it. And then this infertility issue here is debatable depending on which study you read. Because long-term opioid use can affect our endocrine system, there are cases where they think infertility was caused by chronic opioid use. But the correct answer here is B. Yeah, there's a lot to unpack on that one.
Is that really what you advise patients, if they're willing to?
Yeah, we get them off, and I actually, I don't think we've ever. I tell them to get off, and if they're actively trying to get pregnant or going to infertility treatments, I get them off. And I've never had Carrie and Josh and Matthew, I've never had anyone argue with me on that. Usually they'll come in and say, hey, I'm pregnant, I want to get pregnant, I'm starting infertility treatments, how do I get off this? I don't know if you guys have any difference. With the exception of maybe some patients on methadone maintenance from prior heroin addiction, then yeah, I would keep on because you worry about you increase the craving during pregnancy, yeah. But yeah, that's what we recommend, yeah. And most OBs will too. I haven't seen an OB ever ask me to keep them on it yet. So number 10, after determining that non-opioid therapies are inadequate for a patient's pain, which of the following are the 3 most important things to have in place at the beginning of your opioid trial? So, I heard a C out there. Is everyone agreed on C? Yeah, if you can do psychological testing, I'm a huge fan of that. We do it in our office before we write anything, but that's not available everywhere. Family history, important, especially for addiction risk, but medically, legally, not as important as C. And then D's good idea, but you're gonna miss, you should do a urine drug screen before social work or as part of your lab workup. So 11, while all the following behaviors might merit investigation in a patient receiving long-term opioid therapy, which would most strongly prompt your concern for a possible opioid use disorder? I didn't like this question, but I'm open. Yeah, there's a lot here too.
Negative meaning.
Yeah, so negative meaning you're prescribing the medication, say it's oxycodone, and their urine drug screen comes up negative for the opioid.
I would say B.
Yeah, so B, that can definitely be a trigger. It may not always be, so I think B is a viable answer. I think D is also. D is probably going to be your textbook answer, but I agree. If they're coming in with recent family problems, and then C, that can be, a really early sign of opioid misuse or addiction. So D is probably your strongest, but I think any of those could be a sign of opioid misuse or substance abuse. What? You think B? Okay, yeah, so you think B, yeah. So
Which one is it, D or B?
I think you're equal on there. I think both are huge red flags, especially if B is pretty acute. They've been pretty stable. Yeah. Yeah. I'll give you credit for B or D. I thought this was a poorly worded question. And both are red flags to me. Actually, all 4 of those, quite frankly, are red flags. I want that. They prompt further investigation, yeah. Questions on that one, comments? Okay. 12, so this is gonna be, take some time on this one, I'll read it. So in transitioning an 80-year-old patient from 180 milligrams of morphine to oxycodone, and you want incomplete cross tolerance, which of the following would be an appropriate initial dose? And then it gives you some basic calculations there. So you want to take this morphine into oxycodone. What dose of oxycodone are you going to prescribe? What would you guys do on this one? Yeah. Is that you had, Carrie? You're the boss? Okay. Yeah, that's what I do. I'll do like another minute here. And if someone wants to see a calculation that's afterwards come up, we can show you our math and reasoning on it. Yeah, there's a lot better options in this one than they give. A is probably the best answer. B, I'm going to take out right because you'd be putting them on a higher dose. That'd be 240 milligrams of oxy, which is close to 300 milligrams of morphine. You'd be doubling that. Oxycodone IR, 5 milligrams every 4 hours. That's 6 tablets a day. So you'd be looking at about 30 milligrams of oxycodone, so about 45 of morphine versus 180. So that's about a 75% cut. It's pretty big. If it was methadone, that'd be great. And this one is 10 milligrams every 6 hours, so 4 a day. So that'd be 40 milligrams of oxycodone, so about 60 of, so A is your best answer, but yes, that 25 to 50% gives you a lot of clinical wiggle room, but yeah, so. This is 13, of the following, which is an appropriate reason for tapering and discontinuing opioid medication and not a situation that calls for further investigation and increased monitoring? Yeah, it's pains resolving. This is your post-op patient, has them for 3 to 7 days, they get better. They usually stop it themselves, so. All right, last one here. I think so, okay, I didn't lie to you, okay. What is the most important piece of information when educating patients and their families about naloxone use? Yeah, D. This is the give and go. You give it, you go to the hospital. Intermountain's doing a big goal work this year. Because illicit fentanyl and heroin are so high, we're trying to flood the communities with naloxone so that it becomes like a first aid kit, you know? So anyway, make sure, thank you for attending. Thank you for putting up for with us. We enjoy being here. Thank you, Dr. Romankowski and Dr. Minori, for being here on their personal time and being with us. Dr. Ockey will be with us next year.